I remember right around the year 2012, I would go out and I would minister. Chandler was just talking about it. I would minister to people and I would watch them be healed, set free, and delivered. And I would go home for days in the dark, under the covers with the curtains closed. I was plagued by depression and rejection. And the main thing the enemy would try to tell me is that I was alone. He would say, yeah, you do all of that. And if you were to die today, they would find another Tasha. Let me tell you something. This is the testimony. I remember being in that dark room. I remember the curtains closed. It was so dark that my roommate, who was my cousin at the time, she came and she told me, Tasha, I can't take it. I got to move out. She left and went to one of our family members' house. Dark place. I was in that dark room crying in my bed. And the Lord came to me. He said, Tasha, get up and wash your face. Because I'm never alone, no. I got up. He said, for one thing, he said, you've been calling it the wrong thing. You're walking around saying you're depressed. This is rejection. Depression is a branch off of the root of rejection. So you've been cutting off branches, but tonight we're going to get to the root.
I'm not forsaken, never alone. The God of heaven calls me his own. He's not just seated upon the throne. I know he's right here inside my home. I've got a treasure here in my heart, and in my weakness it won't depart. I have a Savior who will abide. He's not just with me, he lives inside. Just go ask Daniel if our God will bring you out, and he will testify. He shuts the lion's mouth. Go ask those Hebrew boys if he'll stick by your side. They will identify the fourth man in the fire. They'll tell you, he's in the room. He's in the room. I've got a treasure here in my heart, and in my weakness it won't depart. I have a Savior who will abide. He's not just with me, he lives inside. So go ask Daniel if our God will bring you out, and he will testify. He shuts the lion's mouth. Go ask those Hebrew boys if he'll stick by your side. They will identify the fourth man in the fire. They'll tell you, he's in the room. He's in the room. Oh, yes he is, yes he is, yeah. They'll tell you, he's in the room. Yes he is. He's in the room. If I search the heavens high, he's there. If I search the earth below, he's there. If I make my bed in hell, he's there. No matter where I go, he's there. Where can I run from his spirit? He's there. Where can I go from his presence? He's there. Even in the deepest depths, he's there. No matter where I go, he's there. If I search the heavens high, he's there. If I search the earth below, he's there. If I make my bed in hell, he's there. No matter where I go, he's there. Where can I go from his spirit? He's there. Where can I go from his presence? He's there. No matter where I go, he's there. No matter where I go, if I search the heavens
right around the year.
The warmth of the sun, when I give my heart, it will be completely, or I'll never give my heart. And the moment I can feel that you feel that way too, it's when I fall in love with you. And the moment I can feel that you feel that way too, is when I'll fall in love with you.
He left no time to regret, kept his dick wet with his same old safe bet. Me and my head high and my tears dry, get on without my guy. You went back to what you knew, so far removed from all that we went through. And I led a troubled track. My hearts are stacked, and I go back to black. We only said goodbye with words. I died 100 times. You go back to her, and I go back to us. I love you much. It's not enough. You love blow and I love puff. And life is like a pie, and I'm a tiny penny rolling up the walls inside. We only say goodbye with words. I died 100 times. You go back to her and I go back to. We only said goodbye with words. I died 100 times. You go back to her to black. I go back to, we only said goodbye with words. I died 100 times. You go back to her and I go back to, we only said goodbye with words. I died 100 times. You go back to her and I go back to black. Can never mend the careless whispers of a good friend to the heart and mind. Ignorance is kind, there's no comfort in the truth. Pain is all you'll find. So unsure as I take your hand and lead you to the dance floor. As the music dies, something in your eyes calls the mind, the silver screens, and all it says goodbye. I'm never gonna dance again.
Legacy companies with diverse cultures have evolved together, creating a unique and dynamic Caribbean force. Aventa is a new identity for our group's pharmaceutical and healthcare business. Aventa evokes the word advance, and working together to advance health while innovating is at the core of our identity.
We want to be a regional pharma company and provide this simplified solution to the market and really deeply engage in the health ecosystem in the Caribbean. And that really helps where you have an identity that you can fly a flag behind. And we all understand what we're working towards together.
I think that I am excited about this opportunity because I feel it will open up the doors for travel and to experience the different culture in the different companies.
I'll tell you what I like about it. Nothing brings a team together like now operating under one name. So I look forward to seeing those synergies occur across all the organizations and all the companies.
Hi everyone, my name is James Walker. I'm the Group CEO for Aventa regionally, and I want to welcome you all to this continuing education seminar at hosted by Aventa Jamaica. We're really happy that you're here. We're really happy that you are focused on advancing yourself. Our purpose at Aventa is advancing health, enhancing lives. So you're both advancing and enhancing today. The topics are super relevant. Oncology, GLP-1s, good distribution practices. These are things that are going to help you and your customers and the healthcare system and society in Jamaica thrive and prosper. Thank you so much to the speakers, to the panelists, to the hosts, and definitely to my team, Glennis and company in Jamaica for putting this on. I hope you have a wonderful day, and I'm going to see you online very shortly. Thank you.
Good morning, everyone. My name is Glenise Durant, the CEO for Aventa Jamaica, and welcome to our 2026 Continuing Education Seminar. It is truly a pleasure to welcome you to today's Continuing Education Seminar, held in collaboration with the Pharmaceutical Society of Jamaica. I wish to extend warm greetings to the Pharmacy Council of Jamaica, members of the Ministry of Health, and to the Pharmaceutical Society of Jamaica, led by its President, Dr. Tyrone Smith. Special thanks to our distinguished speakers, Dr. Sean Moncrief, Dr. Jamie Lee Foote, and Dr. Keisha Allen Dugan, and our moderator, Jeeta May O'Sullivan, who will share their expertise with us today. To our pharmacists and students joining us virtually, our regional colleagues across the Caribbean, principals, our Aventa Jamaica staff, special invited guests, and the team who worked behind the scenes to make this seminar possible. Welcome, and thank you for being a part of today's discussion. Looking at today's agenda, it's clear that this session is designed for where pharmacy is now, and more importantly, where it is going. From breast cancer treatment advancements to good distribution practices, these are not just abstract topics. These are the very issues showing up in your pharmacies, your consultations, and your day-to-day decision making. Because the reality is, pharmacy has evolved. It's no longer just about dispensing prescriptions, it's about interpreting complex therapies, managing patient expectations, and sometimes carefully navigating what Google told the patient 5 minutes before they entered the room. And I think you can all agree that might be one of the more challenging parts of the job. But it also highlights something important. Pharmacists are more accessible than ever and more trusted than ever. And with that comes responsibility. The responsibility to stay informed, to stay sharp, and to stay confident in your clinical judgment. That's what today is all about. This seminar is not just about earning credits, although we all appreciate those. It's about strengthening your ability to respond to real-world situations, whether it's understanding the nuances of new treatment options, advising on weight management therapies that are rapidly gaining attention, or ensuring compliance with proper distribution standards. The knowledge shared today has immediate practical value. And to our colleagues joining across from the Caribbean region, your presence highlights the strength of regional collaboration. While we may be in different locations, the challenges we face in healthcare are often the same, and so too are the opportunities to improve outcomes together. As we move through the sessions, I encourage you to ask questions, share perspectives, and actively engage. Because the true value of today lies not just in what is presented, but how it is interpreted and applied. In closing, I want to commend our partners for supporting an initiative that prioritizes professional development and excellence in pharmacy practice. And to all our pharmacists here today, thank you for your critical role that you play in healthcare. Your impact is felt every single day, often in ways that go unrecognized, but never unimportant. Thank you. And so, I now hand over to Dr. Tyrone Smith, the President of the Pharmaceutical Society of Jamaica, for him to give his opening remarks.
All right, good morning, and thank you. Glenise Durant, CEO of Aventa. Thank you for that warm greeting just now. And I know all the names have been mentioned, so I'll just observe that to save some time here this morning since we are already a little bit behind. So I want to just take this opportunity to speak on what is happening here. Aventa Jamaica. When Aventa Jamaica came to Jamaica, a group of us from the Pharmaceutical Society of Jamaica decided that, it would be a good idea if we, just organize a visit, introduce ourselves, and to meet with this new CEO. And we're glad we did, because a partnership was forged out of that. And that partnership has been growing stronger and stronger as the years go by. This morning, Aventa is putting on this another seminar for our pharmacists, pharmacy interns, pharmacy students, and all our other stakeholders. And of course, you know that the boundaries are now broken down, so you don't have to be in a physical space anymore. And that is why, we welcome persons that are across the region to join us this morning. I want to thank Aventa, because one of the constitutional responsibility of the Pharmaceutical Society of Jamaica is to provide continuing education and to ensure the continued professional development of our pharmacists. And we see where they have jumped on this, and they have been spearheading this whole thing about ensuring that our pharmacists are kept in the loop and kept abreast of what is happening, all the new happenings in the industry. If you look at the topics that are presented to us this morning, then you will see that, as Glennie said, it's not just arbitrarily, but they are carefully selected topics that are relevant to this particular time that we're in. And I want to thank them for that. As we move forward, I would want to take this opportunity also to remind our participants of our upcoming conference this year, our 41st annual conference, under the theme Pharmacists Advancing Healthcare Through Innovation, Policy, and Practice. And as we advance healthcare, there's something particular that I want to mention this morning, because the Pharmaceutical Society of Jamaica has been on this thrust to speak about professional ethics. And we want our members to ensure that we remember that our profession is a noble profession, one that was built upon integrity, trust, and the confidence the public place in us. And I want to just say to us, let us continue to uphold that banner. Now, we have a responsibility to ensure that when we offer a pharmaceutical services, it is efficient. We have a responsibility to ensure that our product choices are from reputable organizations such as Aventa Jamaica. And I want to put that out there, because we see where other players in the market are bringing in stuff, and we have to ensure that the quality of products that we bring to our patients are of the highest standard and quality. So with that said, I want to encourage everyone to enjoy the proceedings here today. Ensure that you're not just here to garner another CE credit, but to sponge up the information and to learn and put that in practice, so that when you go back to your practice site, your patient can benefit from what happened here today. God bless you. Have an awesome day.
Thank you, Dr. Smith. And I would like to introduce the audience today to our chairperson, Gita May O'Sullivan. So Gita, she's a seasoned marketing and business leader with over 12 years of senior experience in the pharmaceutical industry, including more than 7 years in strategic management. She brings deep expertise in international client relationships, having worked with global pharmaceutical companies such as Roche, Bayer, AstraZeneca, Novartis, and Cipla. Throughout her career, she has held senior leadership roles across sales, marketing, and general management. She currently operates as a consultant and trainer in sales and customer service. Gita May has a strong track record of driving business growth, leading high-performing teams, and implementing quality systems aligned with international standards. She has successfully led large-scale transformation initiatives, including ERP implementation, divisional restructuring, and strategic planning, resulting in significant revenue growth and operational efficiency improvements. Gita holds an MBA from Nova Southeastern University and a bachelor's degree in marketing, complemented by professional training in strategic management, corporate governance, and quality management. Gita is an avid gardener, and Gita is also a woman of God. Welcome, Gita, and I hand over to you.
Good morning to everyone. And I come in agreement with our previous speakers, Tyrone, my friend right here, and Glennis, our CEO. It is indeed a pleasure to be here. There's just a simple thing, and I just want to tell you that I have Sam and Kirk here with me, so they work alongside with me this morning. And I have a simple 30-second activity that must be done. It's called an emoji check-in. Last year we did the one check-in. We're going to do an emoji check-in this morning. We want you to just drop your favorite fun emoji in the chat, or just use your reaction button for those of us who know what it looks like on Zoom, and light up the platform. That's what we're starting with this morning. So everybody has to light up the platform. Is it happening? There we go. Yes. Absolutely. I will tell you when to stop. Light it up, because when we're at other places, we use lighters. This morning, it's about our emoji. And thank you for doing that, Sam. You are the greatest, and Kirk. Aventa will be giving away some gift baskets that are always good to have. I want to let you know that this morning, we're giving away a basket for our doorbuster, and who we call our early bird person who came here first, and also the first person who registered this morning. And Sam and Kirk has been so good enough. We have that information right at our fingertips. So we want you to know that we're in serious business this morning. Our doorbuster, we want to know that we had a very important person here with us from Pharmacy Council. We want to recognize, but our doorbuster this morning is no other than our 92-year-old Claire Law, our pharmacist. And so her gift basket is ready. And our first registrant who will receive a gift basket is Celia Banton. So clap yourself, Celia, and clap yourself, Mommy. At 92 years old, we want to wish for you all the best. So I want you to know that you're to stay tuned, because Aventa has a package ready for you. And we want to also take this time to acknowledge and share our condolences with the family, staff, and the entire pharmacy community for the passing of Trisha Marie Kushlani. She was a pharmacist and a pharmacy owner. And we say, gone too soon. Take your rest, our sister. We're ready now to get started. It is a comforting reminder this morning that we are awakened to God's new mercies and his unfailing love, for which we are indeed grateful. Last year it was under New Aventa. We hosted our first virtual CE, and our registered complement, same time last year, was 1,000 pharmacists. Same time this year, we have 1,150 registered pharmacists. So you can clap again in the chat, because we're given another opportunity to be together again with great minds and movers and shakers of this industry, to once again share and gain knowledge and chart paths towards better healthcare. We are proud here at Aventa to serve you, and as such, we just want to share a very special moment where we have been awarded. We are not even, well, I am speaking it into being. We have been nominated by the Jamaica Chamber of Commerce for excellence in the Best of Chamber Award for large enterprise, just in a matter of 2 years. It doesn't get any better. That's awesome, Tyrone. So we can learn with each other in this separate space and place. Today is about conversations with great people. From the book Mindset Reset, it says change embracers and pace setters are go-getters. There is always a bright future for them. Today we'll be exposed through knowledge to the change embracers, to the pace setters, and the go-getters. As we listen to breast cancer subtypes and treatment updates, we listen to GLP-1 receptor agonists and obesity management and good distribution practice and retail pharmacists. All this and more truly speaks to a bright future for the healthcare industry. So a few housekeeping highlights. All mics will be muted. and reopened during the question and answer session. Questions and comments are welcomed in the chat and will be addressed within the appropriate window of opportunity. Welcome. It's a pleasure to have every one of you on board. We're going to get right into the meat of the matter. I've said more than enough, and I have to make sure that my CEO is very comfortable with the amount of time that I take. So, what are we going to do right now? We're going to head right into what we know we do best, providing you with international, top-class, quality presenters and presentations. We're going to jump right into this morning. Our first presenter, presenting on GLP-1. I want to make it very clear. It is G for good for God. GLP-1 and not J for GLP-1 receptor agonists and obesity management. We have with us one of our own, Dr. Keisha Allen Dugan, no stranger to us here in the world of pharmacy. And let me tell you something, to have condensed and summarized her achievement, given Keisha's age, which I will not say, was indeed something for me. It was reading a book. My pleasure it is to introduce her, and would like to confess that time would not permit to properly detail her many achievement and accomplishment. In summary, however, she's presently a clinical pharmacist, lecturer at the University of the West Indies in the Faculty of Medical Science, where she lectures in the area of pharmacology. She's also the course coordinator for Advanced Pharmacy Practice Experience. Her specialty areas are clinical pharmacy, medication therapy management, and ambulatory pharmacy. Mrs. Allen, Dr. Keisha Allen Dugan, is no stranger to this area, as she has given a number of presentations and lectures on diabetes care and guidelines, epilepsy, counterfeit drugs, to name just a few. So today, she will speak to us on GLP-1 receptor agonists and obesity management. She will speak to us so that you can speak to our patients. We welcome her.
Thank you so much, Gita May, for that introduction, and a pleasant and happy Sunday. Good morning to my colleagues who are online, and also to my colleagues who are just across the room this morning. When I got this topic, I was a little flustered because it's a trending topic, and there's a lot of information and misinformation going on about our GLP-1 receptor agonists. But this morning we're going to clear up all of the misinformation, and we're going to educate our pharmacists and our healthcare professionals as well on how we actually position these drugs for use. So the topic today, as Gita May said, is GLP-1 receptor agonist and obesity management. But one of the things we need to discuss before we get into the topic is, why does this matter now? Why are we talking about these drugs now? Why are we talking about obesity management? So obesity management has shifted from lifestyle-only language to chronic disease treatment. And these agents, or GLP-1 based agents, they now affect not only weight, but also glycemia, cardiovascular risk, and in some cases other metabolic outcomes, which you will see coming out later. Now, social media, as good as it is, it has accelerated demand, but there's also a lot of misinformation, unrealistic expectations, and unsafe sourcing of these products. So our objectives today, we have 6 objectives to go through, and in the interest of time, I won't even go through each of them individually. You can see them on your screen there. They are quite heavy. But at the end of the presentation, I can assure you, you would be able to achieve all of the objectives that you see there. So let's look at obesity and the epidemiology. What is happening where obesity is concerned? So we know that obesity is the global epidemic. And you hear it a lot in our Ministry of Health drive in terms of moves and the rise in terms of these non-communicable diseases, of which obesity is one of them. So just a snapshot, obesity continues to rise worldwide, and it affects adolescents, it affects adults, and even young children. Now in 2022, 1 in 8 people in the world were living with obesity. In 2022 again, 2.5 billion adults were overweight, and of these 2.5 billion adults, 890 million were living with obesity. Now, if we look at our children, in 2024, 35 million children under the age of 5 were overweight. Over 390 million children and adolescents aged 5 to 19 years were overweight, including 160 million who were living with obesity. So this is no joke. Worldwide adult obesity has more than doubled since 1990. And shockingly enough, in adolescent and obesity, it has quadrupled. So we are heading in the wrong direction. So let's jump into our first objective, where we're going to be describing the mechanism of action and key physiological effects of GLP-1 receptor agonists. Now, before we even look at the mechanism of action, we have to lay the foundation. So we need to look at some definitions of obesity. So the WHO describes obesity as an abnormal or excessive fat accumulation that presents a risk to health. The American Association of Clinical Endocrinologists, they say obesity is a complex adiposity-based chronic disease where management targets both weight-related complications and adiposity to improve both overall health and quality of life. And the European Society of Cardiologists considers a person being obese if they have a body mass index of over 30 kilograms per meter squared. But even though we have always been using BMI, there are some limitations to the use of BMI. And I'm sure in your reading you have seen that, where people are saying you can't always rely on BMI. And that's true. BMI is a screening tool that is based on the patient's height and weight. But in terms of the limitation, what we have seen is that it overestimates and it underestimates adiposity. And when we talk about adiposity, we're talking about total fat content. We're talking about where the fat is, how much fat you have, and what is the fat doing. Because we have to remember that fat is metabolically active. So let's look at the limitations of BMI in a little bit more detail. So there's no distinction between fat and muscle. BMI cannot differentiate between body fat, muscle mass, and bone density. And if you really think about it, if you look at a very highly muscular athlete, he or she may be incorrectly classified as overweight or obese. Now, BMI also ignores body fat distribution. Where is the fat? It cannot account for it, because we need to remember that your health risk increases because visceral fat is actually more metabolically active, and it causes more issues when you relate that to your subcutaneous fat. It is also inconsistent across populations. So for persons of Asian ethnicities, because they have lower BMI, they have a higher health risk if you look at that population. And of course, we know about sex and age variations. Women tend to have higher body fat percentages than men at the same BMI, and elderly individuals also have higher fat mass than younger people, but our BMI calculations do not distinguish between this. So the definition that we're going to use today is actually coined, or it was coined by the Obesity Medicine Association, and they defined obesity as a chronic, relapsing, multifactorial, neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass, physical forces resulting in adverse metabolic, biomechanical, and psychosocial health consequences. That's a mouthful. But really and truly, what this is saying is that they're not just looking at just the presence of the fat. They're also looking at what the presence of the fat is doing to the individual. Just a second. Okay. So in terms of the etiology of obesity, we have learned and we have seen that it's complex, it's multifactorial, including individual related and environmental factors. And some of these environmental factors that can cause that imbalance in your energy intake and your energy expenditure, it reflects the individual decisions that are influenced by biological and genetic factors. So we have to understand that persons who are living with obesity, there are different factors that are shaping what is going on with the individual. There may be financial, societal, and social network factors. When we look at the environmental factors, these include things like changes in food production. We now have very, very ultra highly processed food. Persons are not walking where they're going anymore. They're jumping in a taxi, or they're just driving from right here to point B, which is maybe just less than 100 meters down the road. And also there's an increase in sedentary lifestyle. So all of these are contributing to persons living with obesity. Oops, trying to get this to move. Okay. So in 2017, the AACE and the ACE suggested a new diagnostic term for obesity in their position paper. And this new term is ABCD. What does this mean? It means adiposity-based chronic disease. And why? Because when we talk about adiposity, which I said before, it looks at abnormalities in the mass distribution and function of the adipose tissue. And because of these abnormalities in the mass and distribution and function of the fat tissues, these can lead to long-term complications and health risks. And as such, the patient now has these chronic diseases as a result of the obesity. Now, this terminology is not solely based on BMI, but it takes into consideration obesity as being a chronic disease state. So when we talk about obesity and the dysfunctional adipose tissue, all of that can lead or predispose an individual to cardiovascular disease. And I'm sure you're saying, aren't we supposed to be talking about the mechanism of action? But before we can get into the mechanism of action of these drugs, we have to understand the foundation. We have to understand what is happening in a patient who is living with obesity, what are the dysfunctions, and what these dysfunctions can actually lead to. So this excess adipose tissue is fat that can accumulate in different areas. So you have visceral deposits, you have ectopic deposits, so you have fat accumulating around the heart, you have pericardial fat, you have perivascular fat. And these increase a patient's risk of cardiovascular disease. Now, in terms of the dysfunction of the adipose tissue, what we have happening is altered lipogenesis and lipolysis. So you have increase in free fatty acids, you have increase in your pro-inflammatory cytokines, there's increase in oxidative stress and reactive oxygen species. What happens as a result of this? There's systemic inflammation and insulin resistance. And then you have the cardiovascular effects. You have it on the myocardium, on the endothelium, and of course on blood vessels. And the clinical effects is, of course, you have endothelial dysfunction, myocardial dysfunction, atherosclerosis, and hypertension. And we know about the neurohormonal activation. You're increasing your RAS system and your increased sympathetic activity. So what I want you to take from this slide is that obesity is a chronic inflammatory cardiometabolic disease. Targeting visceral fat and ectopic fat can help to improve cardiovascular and metabolic outcomes. So what are these complications? And we spoke about some of them. We know type 2 diabetes, of course, because of the insulin resistance. There's the cardiovascular disease, osteoarthritis, liver disease, kidney disease, as well as stroke. So now that we have defined all of that, there has to be a new or an updated diagnostic approach to persons who we're going to consider being obese. So we still have to use our BMI, right? Because BMI is our surrogate measure. It tells you if this person has excess adiposity. After we have done that, then we need to assess whether the person has clinical obesity, and then we move into the treatment of the clinical obesity. It also helps us now to recognize if there are persons who have preclinical obesity, because you may have persons who fall in the range of obesity, but they are not showing any of the symptoms or signs that there are any clinical effects. So, with all of that said, we're going to move into poll question number 1. What does the term ABCD mean? How long are we giving them? Okay, all right. So the answer for that one is actually C, which is adiposity-based chronic disease. But I understand you're hearing cardiovascular a lot, so maybe that is what confused you a little bit, but no problem. We're going to move on. So you might be wondering, why am I going to tell you about diagnosis, and we're pharmacists? Yes, as pharmacists, we need to understand how the conditions are diagnosed. We need to speak the language of the physician so that when we are giving our advice, when we're doing our pharmacotherapeutic assessment, we can understand exactly what is happening with the individual so we can do better assessments. So I'm just going to briefly talk about these 2 slides that are coming up, and they are from the American Association of Clinical Endocrinologists. So to start the diagnosis, what they do are anthropometric classifications. So they look at the BMI, they measure it, and I know we all know the different classifications of the BMI, so I'm not even going to go in there, but they're on the slide. So the next thing they look at is to assess the body composition, because remember, when we talk about adiposity, we need to know where the fat is, and we have to do tests to analyze where the fat is distributed in the body. So those are done. And then we also look at the waist circumference and also the waist to height ratio. And just a little reminder for waist circumference for males, we want anything from, say, 94 centimeters to maybe 102. That's acceptable. And for our female, it's anywhere from 80 to about 88 centimeters. And we also need to measure the waist to height ratio. And for all individuals, we want that to be 5 or below. All right? So after they have done that, They also need to look at how it is that the obesity is affecting the individual. So they're going to be looking at obesity-related diseases and complications. So in doing that, they are now going to have to ensure that there is a full physical examination done and also a proper history. And the history may be focused on obesity-related issues. There's also lab evaluation, and then they're going to stage the A, B, C, D. Remember that, all right? So in staging the A, B, C, D, now the physician is going to determine if the patient is stage 1, stage 2, or stage 3, depending on the severity of the obesity-related diseases and complications that the patient may be presenting with. So then we get into our treatment approach. So the treatment approach is actually four-pronged. So it's a lot of lifestyle intervention. So there's nutrition, physical activity, and behavior modification. And on top of that, now you do medical management. So medical management is actually adjunct because patients need to be changing their lifestyles in terms of achieving the weight loss that they need to. And when that is not at the goal, then you know add your pharmacotherapeutic agents. So let's get to the stars of the presentation, or GLP-1 and GIP. And or GLP-1 and GIP, these are called our incretin hormones. So they are glucose-dependent insulinotropic polypeptide, that's your GIP, and you have your glucagon-like peptide 1, which is your GLP-1. Now these hormones are secreted from the intestines on ingestion of glucose, and they stimulate the secretion of insulin from your pancreatic beta cells. But they only do this in the presence of food. They have a very short half-life, like about 4 minutes, because they are quickly inactivated by the enzyme dipeptidyl peptidase 4. And they work by modulating central neural pathways and peripheral metabolic processes, providing cardiometabolic benefits beyond weight reduction. So these drugs are actually marvelous. So for our visual learners, this is just a quick snapshot of where the action of the GLP and the GIP hormones work. So they work on the brain, the pancreas, they work in the stomach and the gut. And they also have some anti-inflammatory effects, which we will get into. So my next slide, it looks like a very simple picture, but it's telling you a lot. And we're going to stay on this for a little bit. So in terms of the central effects of our GLP-1 RA, they act on appetite regulating regions of the brain. All right? These are like your hypothalamus or your mesolimbic reward pathway. How they work is that they increase anorexigenic signaling, leading to reduced hunger, increased satiety, and lower caloric intake. Now, sometimes when we eat, we feel good after we eat something nice, right? And then we have some of these cravings. But what the GLP-1 receptor activation does, it reduces the dopamine signaling in these reward pathways of the brain, and it decreases cravings, emotional eating, and the rewarding sensation associated with highly palatable foods. So there are also some peripheral metabolic effects that contribute to weight loss and cardiometabolic improvement. So there is the slowing of the gastric emptying, where patients will tend to feel fuller longer, and they will end up eating less calories. They also influence gut hormones by decreasing the hunger hormone called ghrelin. They also enhance the satiety hormone, and in addition to that, they suppress glucagon release, they reduce hepatic glucose production, and they work on our lipids. So in terms of the lipids, they improve lipid metabolism by lowering your triglycerides and LDL cholesterol, They reduce inflammation in the adipose tissue. They improve insulin sensitivity and decrease visceral fat accumulation. And remember, we said that visceral fat is more metabolically active, and it is also the one that causes more problems. Now, your GIP work alongside your GLP. It's like a synergistic effect. Now, on activation of your GIP, it enhances insulin secretion as well and improves postprandial glucose control. It also influences your lipid metabolism and improves metabolic flexibility. So it allows the body to use both glucose and fat more efficiently as energy sources. So let's look a little bit more on the anti-inflammatory role. So we know that enlarged fat cells, these release pro-inflammatory cytokines like your TNF-alpha and your interleukin 6. And these contribute to insulin resistance and endothelial dysfunction. Now, your GLP-1 receptor agonists, they counteract this inflammatory state by improving glycemic control and reducing glucotoxicity. We know that when the body is in a chronic hyperglycemia state, it's going to promote oxidative stress and inflammatory signaling. So if we can lower the glucose levels, we can actually lower the inflammatory pathways that are seen. So, just to kind of summarize everything, the next slide is going to show you exactly what we were discussing just now. And I'm not going to go into all of it because we did mention some of this. But just to understand that there are some broad drivers for your cardiovascular disease, you can see those include things like your metabolic stressors, your vascular dysfunction, and your cardiac dysfunction. And the use of the GLP-1 on these drivers for cardiovascular disease will help by decreasing your glucagon levels, by decreasing your reactive oxygen species, by increasing cardiac glucose metabolism. And all of these will help the individual to, in addition to lose weight, but to also get improvement in their cardiovascular health. So you see, we're not only looking at the losing weight, we're also looking at improving the patient's overall health. So in terms of the effects and associations, this will actually give you exactly the systems that are involved and what is happening when the action of your GLP-1 gets to those areas. So if you want to remember anything at all, because those were just a little bit too much for you, this slide will help you to understand the specific effects of your GLP-1 receptor agonist and your GIP. So it works on the brain, it works on the pancreas, the stomach, the adipose tissue, cardiovascular system, it works on the kidneys, and of course it is going to help to reduce the weight. So that takes us into objective number 2, where we're going to list the currently available GLP-1 and dual GIP agonists. We're going to look at their indications, their dosing schedules, and routes of administration. So I tried to put this on one slide to just help us to have something that we can just pull on whenever we have our patients coming into the pharmacy. Because it's nice to have one document or one reference where you can just pull up and just, use it as a guide. So the 3 that we're going to focus on today are your semaglutide, tirzepatide, and your liraglutide. So your semaglutide and your liraglutide, these are your GLP-1 receptor agonists, and your tirzepatide is your dual agonist because it works on both the GLP-1 and GIP. So let's start with semaglutide. So semaglutide actually has 2 presentations. It's available as subcutaneous injection as well as oral tablets. Now, in terms of the indication, you can see them on the slide. It's indicated, of course, in type 2 diabetes because this was the initial indication. But then they also got approval for MACE prevention, which is your major adverse cardiovascular event. You also had indication for HFpEF, which is your heart failure with preserved ejection fraction. It also got indication for your metabolic dysfunction associated steatohepatitis, and that is termed MASH. So if that is just too long for you, you can just remember MASH. So the initiation dose is 0.25 milligrams weekly, and you stay on that dose for about 4 weeks. And then after that, you increase incrementally by 0.25 milligrams. And you go up to a max dose of about 2.4 milligrams weekly, which is your maintenance dose. For your oral agent, though, you start at 1.5 milligrams day 1 to day 30. Then after that, you move to 4 milligrams, day 31 to 60. You go up to 9 milligrams, day 61 to 90. And then 25 milligrams, day 91 onwards. So your maintenance dose caps out at 25 milligrams orally. For your liraglutide now, on the slide you will see this is the drug that gives you the least amount of weight loss. So in the studies that they have done, you're only seeing about a 3.75.2% reduction in your weight. So you start out with 0.6 milligrams in week 1, and then you go up by 0.6 milligrams weekly to a maintenance dose of 3 milligrams daily, and you can see the indications there. Now your tirzepatide, this one actually offers the highest in terms of weight loss. So it's about 9.6 to 20.8% in terms of weight loss that can be achieved with this drug. Now you start out with a 2.5 milligrams weekly, weeks 1 to 4, up to a maximum of 15 milligrams weekly, which is your maintenance dose. And you can see the indications there. This actually has an indication for obstructive sleep apnea, and it's also second line for osteoarthritis. And that brings us to poll question number 2. So this says the GLP-1 RAs are only available as injectable agents. True or false? That looks like everyone. Yep, everyone has answered. Oh no. All right, so most of you got it correct. Remember the semaglutide, we have both oral preparation and injectable preparation for your semaglutide. All right, so now we move into objective number 3, where we're going to summarize major guideline recommendations, example for type 2 diabetes and obesity, regarding when to initiate our GLP-1 based therapy. But before I went into the guidelines, I actually wanted us to look at some of the landmark trials that came out where these drugs are concerned. Now, if you recall, when a drug is given approval for type 2 diabetes, the FDA actually mandates that they have to do cardiovascular outcome trials. Now, it's because of these cardiovascular outcome trials where we started to see all of these added benefits. So benefits in MACE, benefits in the weight loss, benefits in the kidney outcome, benefits in obstructive sleep apnea. So I want to highlight the SUSTAIN 6, which looked at the type 2 diabetes and high cardiovascular risk. And what we saw was with semaglutide versus placebo, there was a 26% relative risk reduction in MACE. I remember our MACE is our major adverse cardiovascular events. So your cardiovascular death, non-fatal MI, non-fatal stroke. Now, this is significant for persons with type 2 diabetes because you know that once you have type 2 diabetes, your body is already in this high inflammatory state. And then the cardiovascular issues come on board. If you can reduce the risk of MACE by 26%, that is actually significant. Then we have our step 1, which actually looked at semaglutide versus placebo in overweight or obese patients without diabetes. And the primary outcome was percentage change in body weight. And looking at the slide, you can see that there was a 14.9% reduction in your mean body weight versus 2.4% with placebo. So this is actually significant. Another one that I want us to look at is also the SURMOUNT trial, SURMOUNT-1 trial, which looked at adults with obesity or overweight plus complications without diabetes. And this looked at the drug tirzepatide at the doses 5, 10, and 15 milligrams weekly. And you saw that there were mean weight reductions of about 89% to 96% of the population, achieving about 22.5% of their weight. So what is the takeaway from this? There is a greater average weight loss for persons who are on tirzepatide if they start it early. And this one is actually a high efficacy option for obesity management. So coming out of these trials, we have our guideline directed therapies. And we're going to just highlight a few of them. So the American Diabetes Association Standards of Care in Diabetes, it tells us we initiate these GLP-1 adults with overweight or obesity, if they have type 2 diabetes, should be considered for obesity pharmacotherapy as part of a comprehensive care plan. And the GLP-1 RAs or your dual GIP GLP-1 RAs are your preferred obesity medications. And you can see the agents are semaglutide, liraglutide, and tirzepatide, the ones we are actually talking about today. Now, the ADA, when we look at the type 2 diabetes guidelines, and this is the one we know like the back of our hands because we use it a lot in school when we are writing up our SOAPs, when we have our patients with type 2 diabetes. If the patient has ASCVD or high ASCVD risk, so if they have any heart failure, if they have any kidney issues, we initiate agents with proven cardiorenal benefit. So your GLP-1 RAs are recommended particularly when the ASCVD risk reduction and weight benefit are priorities. And the agents that are preferred are semaglutide, liraglutide, dulaglutide, and tirzepatide. Point to note, for ADA guidelines, the level of evidence for those is grade A. So of course, you know, these are actually highly recommended. Then you have the NICE obesity guidance, which says that you initiate semaglutide and tirzepatide for selected adults with obesity or overweight who meet BMI and the comorbidity criteria, generally within specialist weight management services. And the preferred agents are your semaglutide and your tirzepatide. And another one I want to point out is the 2022 American Gastroenterological Association Clinical Practice Guideline on the pharmacological interventions for adults with obesity. They recommend that you initiate pharmacotherapy as an adjunct to lifestyle interventions in adults with obesity or overweight. So that's specified as BMI of 30 kilograms per meter squared or BMI of 27 kilograms per meter squared if the patient has any weight-related complications such as hypertension or dyslipidemia. And the preferred agents are your GLP-1 receptor agonists. The last guideline, and I didn't even bother to put it on that one because I wanted us to see where they actually recommended these agents. So this is the American Association of Clinical Endocrinologists. And you can see the different areas. So for your MACE prevention, first line, so look at the red arrows. First line, you can see semaglutide and liraglutide in type 2 diabetes. For pre-diabetes and metabolic syndrome or diabetes prevention, they have first line and second line recommendation for your GLP-1 receptor agonist and GIP dual agonist. In terms of CKD, the semaglutide and tirzepatide are recommended first line. For HFpEF, you have them recommended as first line. For your MASH, first line. And we know about the diabetes one as well. But also, I want us to look at the fact that it is actually recommended, semaglutide is actually recommended in osteoarthritis and also in obstructive sleep apnea. The tirzepatide is recommended as an agent that can be used. So there is metabolic benefits for our agents in helping to improve the patient's cardiometabolic outcomes. So how much weight we want the patients to actually lose? We want to ensure that whenever we are asking our patients or encouraging them to lose weight, we set the realistic goals. So we start slow. So as you can see, any weight loss from 2.5% to as high as 15% is going to benefit the patient. You have benefits as in terms of the blood glucose control, your triglyceride levels, as much as remission of type 2 diabetes if the patient loses about 15% or more in terms of their weight loss. So moving into our fourth objective, identify common and serious adverse effects, contraindications, key safety warnings for GLP-1 receptor agonists. Now, what are we going to tell our patients in terms of safety? What are we asking them to look for? So in terms of the serious adverse effects, we know these drugs can cause acute pancreatitis, they can cause acute gallbladder disease, they can cause acute kidney injury. So no matter how wonderful we think these drugs are, of course they're going to come with their little problems. But we can tell our patients that not everyone experiences these problems. All right? In terms of contraindications, there's a black box warning because it has been shown that these drugs can cause thyroid C-cell adenoma and carcinoma in rats, and one case has been reported in clinical trial. It's contraindicated in patients with a personal or family history of MTC or multiple endocrine neoplasia type 2, and it is contraindicated with the concomitant use of your DPP-4 inhibitors because it's not going to offer any benefit. All this does, if you give it with DPP-4 inhibitors, it just puts the patient at risk of toxicity. In terms of key safety warnings, though, we want to ensure that we tell our patients that it can cause hypoglycemia, especially if you use these drugs with their secretagogues, so like your sulfonylureas. It can worsen renal failure, chronic renal failure that is. It can cause a type of diabetic retinopathy, and this is considered, it's actually called NION or NEON, which is non-arteritic anterior ischemic optic neuropathy. And what happens is, for persons who are on semaglutide, they may describe like a blurring or cloudiness of the vision. So you have to ensure that the patients are actually doing their eye test. There is also hair loss that is associated with the use of these agents, but it affects like 1 in 10 persons. And it is due to a phenomenon called telogen effluvium. It is a transient form of non-scarring hair loss, and it occurs like about 3 to 4 months after a physiological or psychological trigger. And in this case, that trigger would be the weight loss. Now, the hair loss is transient and it will return after about 3 to 6 months. So what are we going to tell our patients? How are we going to tell them to identify these adverse effects? So in terms of the pancreatitis, you know, you want to warn them about severe persistent abdominal pain that can radiate to the back. There may be nausea, vomiting, diarrhea. There may be fever. There may be tachycardia. We know the signs and symptoms of hypoglycemia, so I don't need to go into that one. There's also GI adverse effects, and these are notable effects of the agents. They cause nausea, vomiting, diarrhea, abdominal pain, loss of appetite, and fatigue is also very common on initiation. And then there's also UTI that may present in patients. So what you ask them to look for: cloud, foul urine, if there's any burning sensation on urination. Are they going to the bathroom more frequently? Do they have pelvic pain? If there's any blood in the urine, if there's any fever, nausea, or vomiting. In addition to all of that, we also need to have our patients understand the differences and risks involved with some of these unapproved and fake illegal substances that's out there, because there's a lot of hype around these medication. And because of the hype, you know that from time to time you hear that, oh, it's unavailable. So you find that there are compounded agents. There are alternative GLP-1s on the market in the forms of patches, drops, gummies, and there are also the illegal forms. So warn your patients, let them know that they need to use only FDA-approved agents, and these are usually labeled with facts on risk and side effects. They're usually prescribed by a medical practitioner, and they are filled at a licensed pharmacist. Now, for the compounded ones, usually they're not tested. They're usually not approved by FDA. The ingredients that are involved, they may cause health problems. There is not proper labeling, and you often find that they are sent via mail. For the patches and the drops and the gummies, sometimes these don't even contain the actual medication, and it is hyped by influencers because they tell you they use it and they don't give you all the information. They just hype up what it is that they want you to hear so that you can go ahead and find these agents online. And you have the illegal form, so your counterfeit injectables, usually sold via illegal online pharmacies, and sometimes you'll find that they're labeled for research purposes only. And this is raw material, active ingredient that they tell you you need to mix and inject. Now, this is dangerous and this is also illegal. So advise your patients to only use medication from trusted sources. Now we go into poll question number 3. GLP-1 RA therapy has shown to be beneficial in all of the following except okay, so the answer for that one is gout. I never mentioned gout any at all. I've mentioned MASH, I've mentioned obstructive sleep apnea, and osteoarthritis. So our 5th objective, demonstrate counseling points on injection or oral administration technique, storage, missed doses, and recognition of adverse effects for the agents such as semaglutide and liraglutide. And I've put a little QR code on there. You can scan it and tell me if you actually have access to the information. I'm going to just pause for 10 seconds so you can scan and get the information. Now I did it this way because this is actually a poster that you can reproduce. You can put it up in your pharmacies. You can give it to your patients when these things are actually, when these agents are actually prescribed. All right, so in terms of the administration technique, the pen is actually very similar to our insulin pen. So the counseling on administration technique is actually pretty similar. You advise the patients to wash their hands, how to attach the needle to remove both the outer and inner needle caps, prime the injection before, make sure they check the flow, make sure they check the needle, set the dose, prepare the injection site, hold and inject the area, leave the needle in for about 6 seconds, then you remove and dispose and you cap the pen. So important reminders for our patient: rotate the injection sites regularly, inject at least 1 inch away from the last spot. For the abdomen, they need to stay 2 finger widths away from the belly button, and always dispose of the needles in a sharps container and do not reuse needles. In terms of injection site rotation, these are some of the areas that you can recommend to your patients to administer their injection. And in terms of storage reminders, we want to ensure that we remind our patients before first use, refrigerate, and refrigeration temperature anywhere from 2 to 8 degrees Celsius. After first use, it can be fridge or room temperature. Now, with our hot climate, we may have to just advise them to keep it in the fridge, because we can get up to sometimes 34 degrees Celsius on a very hot day. Never freeze though. Don't freeze the medication. So don't put it in the freezer any at all. Don't put it directly on ice. We also want to tell them to protect it from light, keep it in the original packaging, but discard 56 days after the first use and keep it away from children. For the oral presentation, however, we need to advise our patients to take on an empty stomach with about 4 ounces of water and wait 30 minutes before eating or drinking or taking any other oral medication. And if a dose is missed, skip that dose and resume the next day. And this is for the oral presentations. And these are usually daily dosing. For injectables, however, the missed dose guidance, we need to ask the patient, in terms of the missed dose, is it within 5 days of the missed dose? If the patient says yes, then we tell them take the missed dose as soon as possible. But if it is more than 5 days, then we tell them skip the missed dose, resume on the next scheduled day the following week. All right? No, and that's for your weekly dosing. For your daily dose, we ask our patients, is it still the same day of the missed dose? And if the answer is yes, you tell them take the missed dose as soon as possible. And if it is no, skip the missed dose and resume on the next scheduled dose tomorrow. So pay attention to this slide because it's different for whether it's a weekly dose preparation or a daily dose preparation. And we're in our final objective, where we're going to learn now how to provide patient-centered education that supports lifestyle modification, addresses social media-driven expectation, and corrects misinformation around GLP-1 weight loss injection. So just a couple of myths that I just want to kind of debunk. And I'm going to just kind of zero in on a few of them. So persons may think that GLP-1s are a quick fix or a magic bullet. The reality? Nope. GLP-1 work best in conjunction with diet and exercise, and they are designed as a long-term, often lifelong component of a comprehensive treatment plan and not a short-term temporary solution for quick weight loss. The other myth I want to debunk is that the natural or compounded alternatives are just as safe. Nope, they're not. And we just saw that on the slide before. The FDA actually issued a warning about the safety risk of compounded GLP-1s. And they actually state that if you're going out there and you're looking for a particular GLP-1 because your doctor prescribed it and you're not getting it, you need to go back to the physician so that they can change the therapy, because they want to ensure that you're not going out there and buying any of the illegal or counterfeit agents. Side effects are minimal and non-existent? No. We know. The studies show nausea, vomiting, diarrhea, and constipation are very common side effects of these drugs. So you have to ensure that you warn your patients. Another thing that they will experience is rapid weight loss, and that can lead to muscle loss. And we're going to just touch on that a little bit later in the presentation. The other myth is you can stop using your GLP-1 receptor agonist as soon as you hit your goal weight. Nope. Studies show that when the medication is stopped, the brain's hunger signals actually return. Sometimes they return a little more aggressively than normal. And the patients then start to regain the weight. But there are ways of getting around this. Now, the final myth I want to talk about is the myth that they work instantly and identically for everyone. Not everyone will have the same results. Effectiveness varies based on genetic makeup, dosage, and lifestyle. And we know this about every drug. I can take a particular drug and I get a particular effect. You take it and you're not seeing the same effect. So what I want you to take away from this slide is that GLP-1 therapies are powerful tools, but success depends on realistic expectations, evidence-based information, and ongoing lifestyle support. And our role as pharmacists is essential in setting the record straight and supporting patients on this long-term journey. So remember, we spoke about the muscle loss. The muscle loss is real, but what are the factors that contribute to the muscle loss? There may be comorbidities involved, there's aging, there may be inadequate protein and nutrient intake, there may be physical inactivity. What can we do to prevent this? We need to practice resistance training. We need to do aerobic activity at least 150 minutes per week. And we need to ensure that there's protein intake of about 0.8 or more grams per kilograms per day. And this will help us to prevent this muscle loss that's seen. I'm sure you have all heard about this famous Ozempic phase. What is it? How can we avoid it? So the Ozempic phase is actually the changes in the face that can happen with the rapid weight loss. It's characterized by gauntness, sunken cheeks, thinner lips, you get wrinkles, loose skin on the face and the neck. Now, this isn't a side effect of the medication itself. It's actually a side effect of the rapid weight loss the medication can bring. Now, in reading, I also found out that there is something called Ozempic vulva. So if you think about it, it's the same kind of sagging that you will see with the Ozempic face. So you can actually use your imagination and get into it. But what we want to ensure is that patients stay hydrated, they consume enough protein, and in terms of the Ozempic face, we want to ensure that they incorporate a very good skincare routine to help to minimize or to avoid it. In some cases, because the weight loss may be so rapid, some persons may benefit from cosmetic surgery if they can afford it. So what are the patient counseling points that we're going to give to our patients? So the lifestyle tips: avoid fatty, fried, and spicy foods because this can worsen the nausea. Stay well hydrated. Eat small, frequent meals, so don't skip meals. Make sure you get at least 7 to 8 hours of sleep and practice good sleep hygiene. And we want to ensure that we set expectations that are realistic. Let our patients know that these are not miracle drugs. They work best with lifestyle. These are actually adjunct to lifestyle. Now, weight loss is going to vary from person to person. It may take 6 months. The weight may return. There may be the muscle or fat loss that we see with the Ozempic face with long-term use. If we have patients of childbearing age, we need to advise them about contraception and fertility. Some of these agents can reduce the oral contraceptive absorption, so we want them to use barrier contraceptive methods like about 4 weeks after starting, or if there's any dose increase. Now, tirzepatide can interfere with your drugs that have narrow therapeutic index, so we have to ensure that we monitor our patients who may be on drugs like warfarin. Quickly, just to show you what can happen when you discontinue the GLP-1 RAs, just that you can have the information to guide your patients. So remember, when you're treated with these incretin mimetic drugs, you're actually inducing the caloric restriction. So the appetite is reduced, the body weight is going to be reduced, and your energy expenditure is reduced. So if you stop over time, what you find is that the appetite returns, the energy intake goes up, but your energy expenditure go down, because remember, you know, you're at a lower weight. So your energy expenditure is going to go down. And this puts you at risk of weight regain. So patients should be educated on the impact of discontinuation of therapy. What we can advise is that, you know, you start at a low dose and you gradually increase the patient's dose. So this is something that we can do as pharmacists to ensure that when we see our patients coming in with these prescriptions, look at how the dose is actually escalating. So we have our final poll question. So this one says, your patient is taking semaglutide and calls to say he missed his weekly dose 6 days ago. You should advise him how. Okay, so the answer, skip the dose and resume on the next scheduled day the following week. All right, good job. So my final 2 slides. So according to American Association of Clinical Endocrinologists, we want to ensure that we encourage our patients lifestyle and behavioral therapy for those persons who are living with obesity and ABCD. Now, nutrition is important. We want to tell them about caloric deficit. We want to encourage physical activity involving at least 150 minutes of moderate intensity aerobic activity per week, and we can divide that into 3 or more days per week. Of course, we need to incorporate or resistance training of about 2 to 3 times per week, where, you know, the patient uses weights. Then in terms of sleep, you have to screen the patient for sleep disorders. So you find out from your patients if they're sleeping properly, and you help them to promote good sleep hygiene. And look out for any anxiety or depression or any eating disorders. Talk to your patients, because sometimes, you know, and not sometimes, there's a stigma where persons who are living with obesity are faced with. And we look at them and we might say, oh my gosh, why you can't lose the weight? But remember, as we said earlier in the presentation, it's a little bit more than just those intrinsic factors. You have the external factors that affect why our patients end up having to live with obesity. But as pharmacists, we are there to actually encourage them. So what I want to leave with you today, if you don't remember anything else, I want you to note the mechanism of action of our GLP-1 RAs. They work across the pancreas, the gut, the brain, and they're not just weight loss drugs. They're indicated for use, and those are guidelines directed by American Diabetes Association and WHO, and of course the American Association of Clinical Endocrinologists. We need to advise our patients about safety, so we monitor for pancreatitis, AKI, and retinopathy. Counsel our patients, set realistic expectations for them, help them to understand that lifestyle modification is essential. And remember, if we have patients who are of childbearing age, we need to talk to them about contraception and ask them some fertility questions. In order to get our patients to continue on therapy, we need to ensure that we address adherence. So we need to teach our patients about the correct injection technique, how to properly store the drugs, how to clear missed dose. And key message, GLP-1 based therapies are powerful tools for cardiometabolic health, and as pharmacists, counseling drives safety, adherence, and long-term success. Thank you very much for listening, and I want you to understand that as pharmacists, remember, we are the expert on drugs. We are the gatekeepers for drugs. So our commitment to staying informed empowers better conversations, stronger support, and improved pharmacotherapeutic outcomes for our patients. I want to leave you with a quote by Dr. Now, and I'm sure everybody knows about Dr. Now, right? Weight loss is not just about looking better, it's about improving health and extending life. And with that, I leave you my references. Thank you very much for listening, and I hope I didn't give you too much information to bombard you, but I like when my pharmacists are empowered and educated. Thank you.
We will now go into our question and answer session. And Doc, I have one question already submitted that I'm going to just read. It says that it has often been stated that once the patient embarks on GLP-1 agonist treatment, he or she must continue for life, since withdrawing treatment will lead to a reversal to obesity. How true is this?
I did mention that in the presentation. Yes, it can be lifelong, but if it is that we want the sustained weight loss and the sustained improvement in the cardiometabolic benefits, then of course the patient is going to have to remain on it long term. It can also be a discussion with the patient and the physician, because when they go in for their assessments, depending on what the physician is seeing, then if it is that they can pull back on the dose and increase the lifestyle interventions, so in terms of the nutrition, in terms of the physical activity, then a patient may be encouraged or may be advised that yes, you can come off of that higher dose, or you may reduce, or you may come off for a little drug holiday. But if it is that they come off, they have to ensure that the lifestyle activities, the physical activity, and the nutrition is of importance.
Thank you so much, and I trust that we got clarity on that. What an incredible and insightful presentation. Another question arising from in the room is, what are your thoughts on moving fat around the body in certain cosmetic surgical procedures?
Wow. I don't want to. Okay, let me not start there. Now, the fat that they usually move around is the subcutaneous fat. So subcutaneous fat, as I said before, is not, let me not say it's not metabolically active, but in terms of the problems that it may cause, is not as problematic as your visceral fat. So you're not moving your visceral fat, you're moving the subcutaneous fat. But in any case, it's still fat. But exercise and diet can address the problems that may arise with moving the fat around. I can't say that it is going to be any different if the patient is obese or overweight. I can't say if it's going to be problematic. I just know that in terms of the problems that it may cause, I mean, the visceral fat is what is more problematic than your subcutaneous fat. Thank you, sir. You're welcome.
Thank you so much, Doc. Are there any of these products registered by the MOHW?
Well, currently I'm not aware. Right, so I'm correct. No, they are not registered in Jamaica as yet. But of course, we don't know what can happen after this presentation.
Wonderful. So the next question was, will there be any NHF subsidies? I suppose if they're not registered, there won't be any subsidies to start. Have you noted the Monjaro click dial dosage method?
No, I didn't know that one in the presentation.
Wonderful. Weight loss has been highly encouraged in the management of PMOS or PCOS. Do GLP-1 RAs have a safe, effective role in this management?
Yes, it does. Yes, it does. If there was a slide that I had where we're looking at the dose of the different agents, PCOS is one of the indications for the GLP-1 RAs, because remember, the underlying problem with PCOS is the insulin resistance. And if it is that we can target the insulin resistance, we can help with PCOS. So they actually have indication for PCOS. And it also helps to improve fertility.
Thank you so much. Can insulin and GLP-1s be used together?
Yes, they can. So the American Diabetes Association actually recommends that for your type 2 diabetes, depending on what the patient presents with, you can start with your so say for example a patient may be on insulin and they're not getting the effect, or they may be on metformin and not getting the effect. They've been placed on insulin. If the physician is if the physician decides, they can actually put the patient on the non-insulin injectable therapy, which is what your GLP-1 RAs fall under. But of course, in that case, you know, patients would have to be advised on how to recognize like hypoglycemia, which is one of the side effects of being on the insulin and your non-injectable insulin preparations.
All right, thank you very much. Interesting one here. Do you know, I don't know if I missed it, the person says, but this is about reproduction and reproductive age. What effect does GLP-1 have on reproduction, and what contraindications would there be with contraceptive taking as well?
All right, let me tackle the last one first. So for your hormonal contraceptive methods, the GLP-1s have been shown to interact with them, so they make them less effective, which is why in the presentation, when I spoke about persons who are of childbearing age, it is recommended that they go on barrier methods. In terms of fertility, they have actually been shown to improve fertility. So these agents, when you administer them to women of childbearing age. It actually helps to improve fertility. I can't tell you what the mechanism is.
But this
That
this
would
will
need
help
more
our this will help
research.
our declining birth rate.
Yes, yes, it would. Yes, it would.
All right, thank you so much, Doc. A lot of questions online. We'll ensure that Doc gets the questions and that we can get some answers, and we'll email to everyone. Please give Doc a round of applause in the room and show all the emojis online. And we go back now to our moderator.
Absolutely. What an informative, insightful presentation. And to just show our appreciation for this, we're going to ask our CEO to make a presentation to Doc for us at this moment.
So, Dr. Alan Dugan, on behalf of Aventa Jamaica, I just want to thank you for your very engaging presentation. I personally learned a lot and it was very engaging. I see that the audience also had many questions. And so I want to thank you very much and have a great rest of the day. You can actually enjoy the rest of our presentations, please.
Thank you. Thank you so much.
All right,
Thank you.
Take care.
And here we are again. We are going to entreat you right now. I have a basket question, a burning basket question. And I did it, but I'm just saying, do I use that basket question right now? But I want to ask, how old is Aventa? How old is Aventa? I have a burning basket question to give away. There we go, there we go, there we go. So we have a basket giveaway, and we trust we get the name of that person, the first person who gave the right answer. And the right answer is, there we go, 2 years. Clap yourself for that. What are we going into right now? We are going to have with us Shanda Edwards from MSD
I'm
to
here,
make
ma'am.
a presentation.
I'm not physically there, my dear. I'm just here virtually
Fabulous.
with serious
Your
technical issues. So you're just going to have to listen to my voice in the darkness. Good morning, everyone.
Your virtual presence is good. Welcome, Chandra, as you present for us.
Thank you. So, good morning, everyone listening, and thank you to Avento for providing me with this opportunity to speak with everyone. And today I'll be presenting on Gardasil 9, which I know is not a new product by any means, but we still need to utilize the platform to educate those who might not be familiar. So, essentially, in 2012, an estimated 1 in 25 cancers worldwide were caused by 9 HPV types. So those types would be type 6, 11, 16, 18, 31, 33, 45, 52, and 58. Now, if you were to be in any doctor's waiting room, wherever you are in the world, approximately 59 men and women would be diagnosed with certain HPV-related cancers every hour as per a 2012 study. So essentially, HPV doesn't discriminate by age, gender, or lifestyle. So with that said, the ideal time to vaccinate your patients against certain related HPV cancers is therefore before they are exposed to the virus. So 80% of people may be infected with HPV in their lifetime. So for most people, HPV will clear on its own. However, for those patients who...
Hello? Hey, sorry to interrupt. Are you sharing our PowerPoint?
No, sir. I told you I was having some technical difficulties, so I'm not able to share my presentation.
Oh, apologies. I missed that part.
Okay.
Apologies. Please go ahead.
No problem. Thank you. So for those patients who don't have the virus clear on its own, it can continue or develop into certain HPV-related cancers. And so with Gardasil 9, essentially it helps to protect your patients against these certain HPV-related cancers and diseases caused by the 9 types of HPV, as I mentioned earlier. So 6, 11, 16, 18, 31, 33, 45, 52, and 50 in both male and female patients. So in a clinical study conducted in 2012 with over 14,000 women aged 16 to 26, which was an active comparator controlled double-blind randomized clinical study. Essentially, the patients were given the vaccine on day of enrollment and subsequent doses administered approximately after 2 and 6 months thereafter. The subjects were followed up by month 67 with a median duration of follow-up up to 43 months, and efficacy was measured starting at month 7 visit. The efficacy was evaluated in subjects who received all 4 vaccinations within 1 year of enrollment and had no major deviation from the study protocol. And with that, in terms of efficacy, it was proven that Gardasil 9 demonstrated a 97% efficacy against HPV 21, 33, 45, 52, and 58 related cervical cancer, vulva cancer, as well as vaginal cancer. Also, the efficacy of Gardasil against certain diseases caused by 4 specific types of HPV found in the original Gardasil 4, which covers type 6, 11, 16, and 18, were also determined in males as well as females. And it was inferred by comparison in terms of efficacy between Gardasil 9 and Gardasil 4. It had 100% efficacy in vulva and vaginal cancer. It was found to have a 98% efficacy in cervical cancer, 75% efficacy in anal cancer, 99% efficacy in female patients for genital warts, and 89% in males in terms of efficacy for genital warts specifically. So in clinical trials of over 15,000 males and females aged 9 through to 26, Gardasil was shown to be generally well tolerated. Of course, you have your transient adverse effects, of course, so vaccine-related headache, nausea, dizziness, but as I said, those adverse reactions were transient. So that means that Gardasil 9 may be the right option for a patient like Marco, who is doing his general, routine checkup. And of course, the ideal time to vaccinate your male patients would be, of course, prior to exposure and as young as age 9. Likewise, for your female patients, ideal time to vaccinate prior to exposure and as young as 9 years old. And of course, this can be recommended by their physician at a routine checkup. So, what's the ideal time to discuss HPV vaccine? It's a good place to start, obviously before exposure, so as young as 9 and upwards. And of course, whether it be at your pediatrician or your gynae, it's a good place to start to have that discussion. So just to ask for your continued support. And of course, as pharmacists and pharmacy technicians, you guys play an important role in helping to protect your patients. In some cases, your patients are probably sometimes more comfortable having that discussion with you, perhaps more so than the physician, especially post-COVID, where most persons are a little apprehensive about vaccines. And, they probably want to discuss that with you. Just to ask for your support and just to highlight some key information. Gardasil 9 is indicated for patients, both male and female, 9 years and above, for the prevention of cervical cancer, vaginal and anal cancer, and of course, genital warts. In terms of dosing, it should be administered intramuscularly as 3 separate doses according to the following schedule. So first dose at elected date, second dose 2 months after the first, and of course, the third dose 6 months after the first dose. Alternatively, and that's specific for patients 15 years and older. Alternatively, for your patients age 9 to 14, it's recommended a 2-dose schedule. So the second dose should be administered anywhere between 5 to 13 months after the first dose. And if that window is missed, or you've given the patient the second dose prior to that 5th month, then a 3rd dose should always be administered. And of course, contraindications, if there's any person who has hypersensitivity to Gardasil 9 or Gardasil 4, or any inactive ingredient in either vaccine. And that's it from me. Just to ask for your continued support, and of course, continuing to educate the patients. As I said, my biggest, I would say, challenge, in the private market is, post-COVID, having, patients being very wary about vaccines in general. And of course, the stigma associated with, I guess, the younger children being vaccinated for what is perceived as a sexually transmitted disease. And of course, being a Christian nation, I don't think it goes over well with some parents, thinking that their, children might be sexually active. But of course, as stated multiple times throughout the presentation, the whole point of vaccinating with Gardasil 9 is to vaccinate prior to exposure. So, so that's it from me. So thanks again for the platform. And I don't know if there are any questions or doubts or challenges. Feel free.
We want to thank Chandra Edwards for that thoughtful presentation on Gardasil, and we continue to encourage our pharmacists to do as what is necessary in promoting and having that product used. Thank you, Shanda, for that, and I know that you experienced a lot of challenges, but we got over it. We are going into, and in keeping with the area of cancer, we are going into our second presentation for the morning. We have with us today Dr. Jamie Lee Foote, consultant hematologist and medical oncologist, to present to us this morning on breast cancer subtypes, therapies, and the pharmacist's role. Dr. Foote has over 13 years of experience across the Jamaican landscape, both in public and private healthcare. And she is the head of hematology and oncology at Jamaica's public and private healthcare system. She's the head of hematology and oncology at Mandeville Hospital, the regional hospital in Mandeville. And she is also very much in private practice. Following advanced clinical fellowship and training at the University Hospital of the West Indies, where she was subsequently recruited to support the expansion of regional oncology services, she leads cancer care delivery, protocol implementation, and the integration of immunotherapy into clinical practice. She's a member of the National Health Fund's expert panel, somebody to know, somebody to learn from, contributing to oncology drug access, formulary decisions, and national treatment policy. Her speaking engagement in this area have been many. Today, she will bring to us what she knows and share with us what she is good at. And so it is indeed my honor and pleasure to welcome our own Jamaican-grown Dr. Jamie Lee Foote.
Thank you so much for that warm introduction. You're too kind. So I just want to thank the Aventa team for inviting me here today to present on breast cancer in 2026. So this 35-minute presentation basically focuses on bridging the gap between high-level molecular diagnostics and operational pharmacy practice. We will discuss how recent therapeutic shifts impact our daily clinical workflow, verifying regimens, managing toxicity, and overcoming financial barrier to patient access. Now, we have only 35 minutes today to transform how we review these complex regimen at the verification desk. So let's look at a roadmap to how we're going to get there. So our learning objectives today focuses on 4 core pillars. We're going to classify, interpret, select, and apply. First, we will break down the 4 molecular subtypes based on receptor expression and genomic risk profiles. Secondly, we will look at a pathology report to turn the raw biomarker data directly into eligible checks. And thirdly, we will map out contemporary drug classes, including the latest thing on the market, antibody drug conjugates, CDK4/6 inhibitors, and PARP inhibitors, and of course, immunotherapy. Finally, we will translate these findings from trials like the Monarch-E, Destiny Breast 03, Keynote 522, Olympia, and Inavo 120 into seamless pharmacy workflows. So to hit this goal, we have to start where the oncology clinic starts, with the biology of the tumor itself. All right, so now here are 4 molecular subtypes. Now, different texts will show more detailed subtypes, but for the purposes of this presentation, we're going to look at these 4 basic molecular subtypes. So they include luminal A, luminal B, HER2 enriched, and triple negative breast cancer. So luminal A represents roughly 40% of cases. It is characterized by ER/PR positivity, HER2 negative status, and a low Ki-67 index. And we're going to get into what a Ki-67 is. It's a proliferation index. So basically, the luminal A's tend to exhibit a more favorable slow-growing biology and treated with endocrine therapy as one of the major backbones. And actually, some luminal A's, when caught early, it's like the stage 1s, can actually be treated with endocrine therapy alone, omitting chemotherapy. When we talk about luminal B's, this represents approximately 20% of all breast cancers. And here we're looking at patients that are hormone receptor positive but have a higher proliferation index, so a higher Ki-67 than the luminal A's. These patients can also, another definition is also co-expressing HER2. Now, when we talk about hormone receptor positive, HER2 negative with a high Ki-67 proliferation index, this luminal B subtype are actually ideal patients to utilize newer drugs on the market called CDK4 inhibitors, which are usually paired with endocrine therapy plus chemotherapy if the genomic risk assays are elevated. HER2 enriched covers approximately 15% of cases. These are hormone receptor negative, but explicitly HER2 positive. This biology tends to be aggressive and rapidly progressive, requiring an anti-HER2 doublet, plus or minus a doublet. It can be single anti-HER2 or a doublet combination with chemotherapy, with antibody drug conjugates playing a central role in this subtype these days. Now, triple negative breast cancer. Now, the triple negative breast cancer speaks to patients with a pathology report stating that the tumor is hormone receptor negative, so ER negative, progesterone receptor negative, HER2 negative. So you can see here we don't have a traditional target. So previously, chemotherapy was essentially our only weapon, but of recent, and of course, it represented a high unmet need. But recently, data has shown that pairing chemotherapy with immunotherapy, and if indicated, PARP inhibitors, if the patient is germline BRCA positive, yields extremely good outcomes. Now, just to mention that the rest of like around 10 or so % would represent rare and unclassified subtypes. Now, a recent study at KPH, which was a single study, that was recently published highlighted that triple negative breast cancers actually represent 25% of the Jamaican population. And I'm actually seeing similarities anecdotally at my institution. However, we still need to do a formal study about that. And just to mention that triple negative breast cancers tend to be very aggressive. And what we realize with the Jamaican population is that these patients are presenting earlier. So I have a lot of 30 and 40-year-olds in my clinic. And so this is something that we desperately need to address. Now, how do we pull all of this together? Out of this messy pathology report, when we have it. So biomarker testing. So think of this table as your master verification checklist, because remember, when subspecialization for pharmacy oncology, we're moving more towards that because of precision medicine. So you find that maybe over time, your role will change in the system. So this table, think of it as master verification checklist when you're reviewing a breast cancer chart. So ERPR is assessed by immunohistochemistry. Now, a threshold of greater than or equal to 1% defines hormone receptor positivity. Your operational role is to verify endocrine therapy and ensure ovarian function suppression is active in premenopausal patients. HER2. Now, this is evaluated by immunohistochemistry or FISH with an amplification of greater than or equal to 2. Confirm an anti-HER2 agent is present on the regimen and flag if it's missing. HER2 low is another subtype. Now, this is a little paradigm shift that a lot of people are unaware about, and we're going to get into that more in detail. But what HER2 low represents is an IHC of 1+ or 2+ with a negative-ish in situ hybridization. Now, check for, so that would mean that we need to check for eligibility for different drug benefits to the patient. And this would include our antibody drug conjugates, which we will discuss a little later. So the point for this is that you should not assume HER2 negative means that you don't qualify. There's no indication for any treatment. There are treatments out there these days that can target patients with HER2 low disease. When we speak about the Key 67, no, it was invented or there were some researchers in Germany. I think the location was called Kiel. So that's how we get the name Key 67. They discovered this proliferation index. And basically it speaks to how fast the cells are growing. And so you can stain this on the tumor and you can see how fast essentially the cells are growing. And that is how we can basically discriminate between luminal A's and luminal B's when they're HER2 positive and, when they're hormone receptor positive and HER2 negative. So Key 67 of greater than or equal to 20% would be luminal B. And this is an indication for evaluation for CDK4 inhibitors. Now I'm going to talk about PIK3, which is a mutation evaluated by ctDNA, which is circulation tumor DNA or NGS next generation sequencing. The presence of this mutation unlocks eligibility for alpelisib or inavolisib, which are PIK3 inhibitors, PI3K inhibitors. So in this case, which we will discuss shortly, one of the major side effects is hyperglycemia. So glucose checks are essential in this subgroup. Now, germline BRCA1/2 requires germline testing, and a pathogenic variant confirms PARP inhibitor use and also requires focused hereditary counseling, because having a BRCA mutation can also predispose you to other cancers, including in male prostate cancers, ovarian cancers, etc. for females. PD-L1, no, PD-L1 is tested by IHC. Now we look at a combined positivity score of greater than or equal to 10. Now this is required for the use of pembrolizumab in the metastatic triple-negative breast cancer setting before dispensing. Now, while we looked at the standard IHC thresholds for basic subtypes, early stage hormone receptor positive disease requires a deeper layer of molecular stratification. So moving beyond IHC markers, multi-gene genomic assays provide prognostic and predictive scores to guide adjuvant treatment in early stage hormone receptor positive, HER2 negative disease. So for example, Oncotype DX. Oncotype DX is utilized in both node negative and node positive early stage breast cancer. And basically, it answers the fundamental question, can adjuvant chemotherapy be safely omitted? Now, remember, chemotherapy and all these medications have their side effects. So can we de-escalate or omit this chemotherapy backbone in these patients safely without increasing their risk of recurrence and giving them a better quality of life? Now, this genomic assay was actually supported by data from landmark trials like TAILOR-X and RxPonder trials. Another genomic assay is called MammaPrint. It evaluates early stage disease to catch discordance between a genomic low risk profile and a clinical high risk profile. And sometimes we have this discordance that the genomic test is saying, okay, no, the patient is low risk, but when you look on the clinical pathology, they are grade 3 and, or, you know, they have node positive disease. And, you know, so this genomic assay actually helps to kind of discriminate and see how we can appropriately stratify the patient. And this is supported by the MINDAC trial. PAM50 is another, as well as EndoPredict, and these identify intrinsic molecular subtype to assess late recurrence risk. Now, this is more essential, where we use it more commonly in patients, postmenopausal patients, who we have on, and probably an aromatase inhibitor, and we want to see if extending therapy with the endocrine treatment would be beneficial to the patient. So the point here is always confirm that specific genomic assays, when we get to that point in our medical care, result is officially documented on charts and matches the intent of the prescribed adjuvant regimen before hitting release of that drug. Now, while the multi-gene panels give us genomic risk scores, the therapeutic map for HER2 expression has experienced an even bigger paradigm shift. One second. Now, historically, breast cancer was strictly binary. A tumor was either considered HER2 positive or HER2 negative. Now, we know that up to 55% of historically HER2 negative tumors actually express low levels of the receptor, qualifying now as HER2 low. Now, this is significant because that means that patients who were previously classified as just triple negative breast cancers, if we retest their IHC, we can actually find that they may actually benefit from medications that target HER2 low disease. Now, the Destiny Breast 04 trial completely shifted this paradigm by demonstrating a dramatic progression-free survival benefit with trastuzumab deruxtecan, which is an antibody drug conjugate. I'll get more into that shortly. And compared physician's choice chemotherapy and showed a difference of 9.9 months versus 5.1 months. Now, you must actively confirm a history of IHC 1 plus or 2 plus. Now, I just want to show you here that previously, you guys are seeing my pointer. So, for example, IHC 1 plus, right? So basically, IHC is a staining assay. So the pathology or the biopsy is stained, right? The tissue is stained, and you look under the microscope and you basically grade it, whether or not, if it's low intensity, that will probably be a 1. If you're not seeing anything, that'll be 0. If you see 2, when you see 2, it's basically equivocal, and so we'd have to move on to a more specific test called in situ hybridization, either by fluorescence or silver enhanced. And or you might see 3, which is very intense. However, it was either positive or negative. Now with HER2 low, here you have, if you view it on the 10x, you may see it as low, but if you go in and zoom further, you can probably classify and discriminate between IHC of 1 plus, IHC of 2 plus, or what was considered nothing at IHC 0 may actually be HER2 low at a 1 plus. And now, just to even get even more complicated, even though I don't mention it here as yet because it's not fully in prime time, there's an entity called ultra low. So that is even more specific test to see if the patient can benefit from these antibody drug conjugates. And this is extremely important because the Destiny Breast 04 really showed overall survival benefit in these patients. And this was truly an unmet need, and it basically revolutionized cancer care worldwide. Okay. So now that we have completely re-stratified our diagnostics from multi-gene assays to HER2 low zones, let us now look at how this translates into clinical choices. So here is a treatment by subtype decision map. So we're going to go through this carefully. So the first column, we have hormone receptor positive, HER2 negative. And these breast cancers are usually grounded in endocrine therapy. Early stage high risk disease will tend to incorporate medications called CDK4 inhibitors, for example, abemaciclib based on the Monarch E. First line metastatic disease relies on aromatase inhibitors or fulvestrant combined with a CDK4 inhibitor. If you have a PIK3A mutation, we shift to inavolisib or PI3K based inhibitor, while germline BRCA positive patients utilize PARP inhibitors. So even though we have our basic classification, we can further subtype to ensure that patients receive full benefits for their treatment of this condition. Now the next column is HER2 positive disease, and I also mentioned HER2 low here as well, driven by anti-HER2 backbones. Now, neoadjuvant therapy uses trastuzumab plus or minus pertuzumab, which are anti-HER2 medications. Now, plus chemotherapy. Shifting to TDM1, which is an antibody drug conjugate, if the biology comes back showing residual disease. So what happens is that in the neoadjuvant setting, so neoadjuvant pretty much means before surgery. We like to treat a lot of these breast cancers before heading to surgery because it gives us like an in vivo type picture where we can see that the patient is actually responding to the condition. If you remove the breast, we can't actively see that the medication is working because we're supposed to see a reduction in the size. And then when you go to surgery, we look microscopically to see if there's any residual disease. If there is residual disease, then TDM1, which is trastuzumab, and DM1, which is a microtubule inhibitor, is a chemotherapy drug, so it's an antibody drug conjugate, is recommended in this setting. When we speak to metastatic second line, we speak to these patients, the preferred first line is TDXD, which is another antibody drug conjugate. And then in our HER2 low setting, this same TDXD is also indicated. And remember, do not assume that the patient doesn't have an indication. If you see a HER2 negative, we need to really discriminate and see whether or not they're low, IHC 1 plus or 2 plus. Now, our triple negative breast cancers. So this relies on biomarker guided selection, primarily in the metastatic setting. However, in early high-risk breast cancer patients receive neoadjuvant and adjuvant pembrolizumab, which is an immunotherapy combined with chemotherapy. First-line metastatic treatment that's the one that requires biomarker testing to see if they will actually benefit from the immunotherapy. So after getting that biomarker, if the patient shows that the PD-L1 is positive with the CPS greater than or equal to 10, pembrolizumab would be indicated. We can further subclassify and see whether or not the patient will benefit from a PARP inhibitor if they have a germline BRCA mutation. And then later lines of metastatic disease would include another medication, sacituzumab govitecan, which is another antibody drug conjugate. So this map basically gives us the strategic lines of therapy, but those lines are drawn by specific landmark trials, and I just want to highlight these landmark trials again. Now, 6 of them here. Monarchy, as I mentioned, established abemaciclib and endocrine therapy as a standard for high-risk node-positive early hormone receptor-positive breast cancer. Destiny Breast 03 rewrote second-line metastatic HER2-positive standard, showing that trastuzumab deruxtecan yielded a massive progression-free survival of 28.8% versus 6.8 months. So this is the preferred second-line standard in metastatic HER2-positive breast cancer these days. Now, I'm going to mention two of what trials that are my favorites, are very exciting because I know triple negative breast cancer is an unmet need. So the Keynote 522 trial solidified neoadjuvant pembrolizumab plus chemotherapy followed by adjuvant pembrolizumab as a standard of care for early high-risk triple-negative breast cancers, showing improvements across pathologic complete response, event-free survival, and overall survival without requiring baseline PD-L1 testing. The Keynote 355 spoke to metastatic triple-negative breast cancer, and this is where the PD-L1 CPS of greater than or equal to 10 is required. And this showed an overall survival benefit of 23 versus 16.1 months. Now we have quickly Olympia, which demonstrated that adjuvant olaparib reduces distant recurrence and extends overall survival with patients for patients with HER2 negative disease but harbor germline BRCA1/2 mutation. And Inavo 120 evaluated first-line metastatic setting for PIK3CA mutant patients with hormone receptor positive HER2 negative disease. Showing that adding inavolisib or to palbociclib and fulvestrant doubled the median progression-free survival. So let's dive straight into the first core data set. The use of CDK4/6 inhibition. So a closer look of the monarchy, right? So the monarchy trial basically evaluated a highly specific population, patients with the high risk, node positive early breast cancer. The regimen adds abemaciclib at 150 milligrams twice daily to standard endocrine therapy for a duration of 2 years. The 5-year follow-up data confirms a sustained absolute invasive disease-free survival benefits of approximately 7.6% over endocrine therapy alone. Now, this is for patients with high-risk hormone receptor positive breast cancers, right? So with the curves continuing to separate even after the 2 years, just show you right here. As you can see, this is 2 years and the curve is still separating. So 2 years, the patients are treated for 2 years and are still benefiting from this treatment even at 5 years. So because this is adjuvant therapy with curative intent, it's important to verify that patient explicitly meets high-risk criteria. So high-risk criteria would be node involvement, dependent on the tumor size, and it also speaks to the key 67 status as well, which is generally greater than 20%. And this is critical for quality check before dispensing. Now, we are asking these early-stage patients to take this therapy continuously for a full 2 years. To keep them on track, we have to understand the mechanics of their hematologic and cardiac safety. So we're going to get into a little basic biology or physiology for a second, molecular biology for a second. Now, to effectively monitor these agents, we have to understand the cellular mechanisms that dictate their toxicity profile. So, unlike traditional chemotherapy, which destroys the bone marrow of the cells, CDK4 inhibitors cause standard G1 S-phase cell cycle arrest. So if you can recall the cell cycle, and the cell cycle speaks to how, you know, the whole cellular process with the cells being made and everything. So in the cell cycle, we have different checkpoints, and these checkpoints are there to check, okay, is the DNA okay, is the integrity okay for me to go ahead, divide, and produce, you know, the proteins and everything required for cellular division and everything. So there are different checkpoints. Now, here you can see cyclin D, and you have CDK4 here, right? So what happens is that the CDK4 and 6, what they do is when they phosphorylate retinoblastoma, which is here, which is a protein that's bind to something else, a transcription factor called E2F. Once it phosphorylates, it actually releases this transcription factor and goes into the nucleus and basically causes the cell to go from the G1 to the S phase. So G1 is one of G1 S phase checkpoints. So basically it goes in the synthesis phase. So it says, okay, yeah man, go ahead. You can go on and start making your DNA products and we can go through the cell cycle, right? What the CDK4 inhibitor does is inhibits the CDKs from phosphorylated retinoblastoma, because if we keep retinoblastoma phosphorylated, it's unable to release the E2F transcription factor, and then prevents further progression into the cell cycle. So when I talk about, so patients in this case, of course, this governs most cells or all the cells in the body, right? Including white blood cells. So what happens is that neutropenia is a very important adverse effect because the white cells are essentially not being made. So it's cytostatic versus chemotherapy that actually destroys the integrity of the bone marrow that makes all the blood cells in the body. So what this means is that all we need to simply do if the patient is neutropenic is to simply hold the drug, right? Well, obviously after evaluation, but holding the drug is indicated and not just jumping to GCSF to produce more white blood cells. And that's very important because the mechanism for the neutropenia is different, unlike chemo, which is cytotoxic, right? Now, just to mention here that CBC monitoring is very important and is highly predictive. We expect a nadir at day 15, especially of the first cycle. So we need to constantly do our CBC checks. Now, just to mention a very, very important note, ribociclib is one of the CDK4 inhibitors that we are actually using now primarily in the metastatic breast cancer setting. Basically, there is a warning with QT, which can cause a very bad arrhythmia for the patient. So ribociclib possesses a distinct on-target off-tumor affinity to hERG potassium channels, creating a risk for QTc prolongation. A baseline ECG is mandatory before moving on to cycle 2 and subsequent cycles. Now, very importantly, if a patient is on ribociclib and requires an antiemetic, ondansetron should be substituted. If you see that on the prescription, that is a red flag, and the treatment, the medical team should be contacted because ondansetron can also prolong the QTc via different mechanisms. So this is important. So granisetron or Kytril should be substituted in this case. Now, while abemaciclib dominates the adjuvant space for our next target is the PI3K pathway, which takes us into our first-line metastatic management. So just to mention the Ninavo 120, this shifted the landscape for metastatic breast cancer for patients who harbor the PIK3CA mutation, hormone receptor positive, or HER2 negative disease. The study randomized patients to receive selective PI3K inhibitor combined with palbociclib, which is a CDK4 inhibitor that we just discussed, or fulvestrant, versus a placebo triplet. Now, the primary endpoint showed a doubling of median progression-free survival extending from 7.3 months in the control arm to 15 months in the inavolisib group, with a highly significant hazard ratio of 0.43. So, your primary verification would be to mandate that there is a PIK3 mutation confirmed by ctDNA or tissue NGS, next generation sequencing, before the first dose is prepared and administered to the patient. Because it can cause hyperglycemia, we need to verify that baseline fasting glucose were done. Now, doubling progression-free survival is a massive win here, but the mechanism of PI3K inhibitor means we're trading hematological toxicity for metabolic toxicity. So let's look closely at that. Now, this chart basically illustrates exactly why the metabolic toxicities are completely unavoidable when using these medication. Now, for example, why hyperglycemia happens. Now, this pathway is primary downstream mediator of insulin signaling. When we inhibit PI3K to block tumor growth, we are simultaneously blocking insulin action in pancreatic beta cells, the liver, and skeletal muscle. This halts glucose uptake, resulting in immediate on-target hyperglycemia. So essentially, insulin not working properly, the cells are essentially insulin resistant, and you're prone to hyperglycemia. So monitoring protocol is very important when using these medications because of this on-target effect. It happens fast. You must check fasting glucose weekly for the first 4 weeks and on day 1 of every subsequent cycle. If fasting glucose is extremely high, the medication must be held or dose reduced according to safety parameters. So, pharmacist intervention, this can be actively managed. So first, counsel patients who to take medication with food to stabilize absorption. Second, if the patient has a baseline history of pre-diabetes and diabetes, coordinate early with endocrinology and cross-reference with their chart if there's any corticosteroid use, which can even worsen the hyperglycemia even more. So these are little checks that we should do while the patients are on this medication. So we have covered the oral small molecules that target cell cycling and metabolism. Now let's pivot to intravenous biologics that function as molecular Trojan horse. Now this is an exciting time in cancer biology and treatment because we have this class of medication called antibody drug conjugates. Now these are such elegant, I find the mechanism of action so elegant. I'm sorry, these things excite me. Okay, so here we have the antibody. So essentially, we talk about precision medicine. So this is basically an antibody that is linked to a chemotherapy payload, right? Now, we know that when we administer chemotherapy, it goes everywhere and destroys everybody, right? Normal cells and whatever. What we try to do is try to be more specific. So we put on an antibody target. So for example, with trastuzumab deruxtecan, we have the antibody that's able to target cells that have HER2 on as the antigen on the cell surface. So it targets it, right? It has the payload attached, which has the chemotherapy attached, right, via a linker right here. It's internalized, so the antibody binds to the antigen, it's internalized, and there's enzymatic cleavage, releases the payload, which is the chemotherapy, and then it goes into the cell and causes DNA damage and destruction. So it's more specific. Now, the thing is that even though I did say it tries to target as specific as possible, the thing with trastuzumab HER2, which is HER2, which finds HER2 cells, is that a lot of cells do still have HER2 on its surface. It may not be a high amount, but this is why it's a kind of double-edged sword. Because of this bystander effect, it's able to target other cells that are neighboring it, which is why it works in HER2 low disease. So it's excellent for that. But then, of course, you have the risk of it causing other issues. So one of the primary toxicity is interstitial lung disease. So any patient that presents and is there coughing, and you know the patient just started this new antibody drug conjugate, hold immediately, call the medical team, and let the patient get evaluated. Just to mention that it also has high immunogenic potential, so robust anti-emetic prophylaxis is required. Now, saxituzumab govitecan is a TROP2 antibody drug conjugate. So it finds TROP2, which is highly expressed, especially in triple-negative breast cancer. So it is attached to a SN38 payload, which is essentially a prodrug to irinotecan. So one of the primary toxicity here is severe diarrhea. Now, patients with UGT1A128 mutations, which confers or characterizes Gilbert syndrome, have a higher risk of toxicity. So it's ideally best to check genotype before commencing this medication and have low pyramide protocol on board as well. So understanding how these antibody drug conjugates deliver toxic payloads explains why the next trial completely rewrote second-line HER2 standard. So just to mention again, this very fascinating Destiny Breast 03 trial that looked at TDXD versus TDM1. Now, both of these are antibody drug conjugates. I just explained TDXD. TDM1 is trastuzumab that's bound to a DM1 payload, which is a microtubule inhibitor. So, you know, it kind of similar to paclitaxel, right? So it binds internalization and everything. But previously, in second-line metastatic breast cancer, TDM1 was the go-to. And was the standard of care. But this trial actually switched things around because the difference in median progression-free survival was extremely drastic. So basically, it compared TDXT versus TDM1, and the primary endpoint was progression-free survival, and it basically demonstrated a profound extension, 28.8 months with TDXT compared to just 6.8 months with TDM1. So for pharmacist verification, we should, before releasing this high-yield agent, we have to look at the pathology report to confirm explicit HER2 positivity expression or positive FISH amplification, and maintain strict clinical vigilance for early stage interstitial lung disease, right? Now, while antibody drug conjugates have revolutionized targeted delivery, our final therapeutic deep dive looks at mobilizing the immune system via checkpoint inhibition. So just to give a quick thing or mechanism check on pembrolizumab. Pembrolizumab is an immunotherapy. Basically, immunotherapies enhance the immune system to fight the cancer. That's the basics of it. So our immune system, normally, we've been fighting cancers from the day we were born. Our immune system can fight infection. It can also fight cancers. It's when cancers overwhelm the immune system or their mutational changes that we run into a bit of problem. So the immunotherapy helps to enhance the immune system to help the body to fight the cancer. So Keynote 522. Now, this is a trial that looked at early stage triple-negative breast cancer. So it was administered in the neoadjuvant setting with chemo, followed by single-agent adjuvant therapy post-surgery. In this curative early stage setting, PD-L1 is not required. So I'm going to repeat, PD-L1 is not required for early high-risk triple-negative breast cancer, right? And the data demonstrated clear improvements in pathologic complete response, event-free survival, and overall survival regardless of the baseline PD-L1 expression. Now, this is significant because our triple-negative breast cancers, remember, data told you that 25% of our patients are triple-negative breast cancer, and this is higher than what is seen in developed countries like United States that are still sticking to their approximately 15%. So this treatment is extremely important in improving the survival rates for patients with triple-negative breast cancer, which is known to be very aggressive and targets the Black population, right? So in the metastatic setting, however, the Keynote 355 showed a benefit, but only with patients who are PD-L1 positive. Now, the immune system likes, the immunotherapy likes an environment that is more inflammatory. So in your early high-risk triple-negative breast cancer, the melo and the microenvironment is more inflammatory, so the drug works better there. When we come to metastatic disease, it's more of a chronic inflammation, so the environment is not as chaotic and whatever. So you find that it works better for patients that express PD-L1, which is a biomarker. And what is required in this case is the companion biomarker assay, which is the 22C3 assay, is required for testing before pembrolizumab can be used. And basically this assay was studied and pairs with the drug. So if that is positive, then we know pembrolizumab is indicated. If another different brand assay is used, we can't really look at that because it wasn't legally approved to, for the use with pembrolizumab. So we have completed our clinical data tour. Now let's synthesize all these drug classes into a clean operational framework. We'll be done soon. So toxicity monitoring by drug class. We're going to go through these one by one. So the CDK4 inhibitors, myelosuppression is our primary check. Check CBC before every cycle, but note that the infection risk is lower than with cytotoxic chemo because the mechanism is cytostatic versus cytotoxic, because, you know, as I told you already, with the cell cycle, we're inhibiting the growth of the cells, so it is cytostatic, right? Medications like ribociclib, which is a CDK4 inhibitor, but more specifically for ribociclib is the QTC prolongation, requires baseline and serial ECGs to screen for this. And of course, enforce a strong preference for granisetron, which is Skytril, over ondansetron on patients with ribociclib. Abemaciclib, diarrhea is the primary dose-limiting toxicity. Counsel patients on early self-reporting and ensure they have loperamide at home to start at the very first loose stool. Trastuzumab deruxtecan, the TDXD, monitor for interstitial lung disease at every single encounter. Grade 1 requires immediate hold, while any signs of grade 2 or higher requires permanent discontinuation. There's no safe retrial protocol for this medication. Saxituzumab govitecan, the other antibody drug conjugate, severe neutropenia and diarrhea dominate. So ensure UGT1A128 genotyping, which looks for the Gilbert syndrome, is checked prior to the first dose, and utilize prophylactic GCSF if the patient is homozygous for this. Alpelisib and PARP inhibitors. Now, alpelisib requires strict weekly fasting, glucose. Remember, I told you about hyperglycemia, because these PIK3 target a lot of different things, especially when with the insulin pathway. So we have to manage hyperglycemia and check for it. While PARP inhibitors require monthly CBC checks to monitor for profound anemia and long-term myelodysplastic syndrome, which is a low risk of this condition. So class summaries are great for baseline knowledge, but let's look at concrete cycle-by-cycle lab calendar. I won't focus too much on this because you can just read it. It basically just tells you how the drug, the class of the drug, and what the monitoring should look like or import. There are other monitoring strategies, of course. Everything is based on the patient and individual, but these are the important ones that you guys can look at a later time. So let us look at supportive care fixes that prevent harm. So as oncology pharmacists, these interventions are entirely within our clinical purview. These are not mere suggestions, they are standard safety adjustments we should make at the verification desk. So as I mentioned before, ribociclib and the antiemetics, I'm stressing this over and over. Ondansetron also prolongs the QTC, so we need to ensure we have make that substitution, because the physician may write it, but you know, you are another important check. So just verify that the substitution is made and notify the care team. Just to mention a note on tamoxifen and antidepressant. Tamoxifen is a prodrug that relies heavily on the CYP enzyme to be converted to its active metabolic state, endoxifen. So paroxetine and fluoxetine are potent CYP-D2/D6 inhibitors that completely blocks this conversion. So basically, the fix is to use another antidepressant like venlafaxine. It provides minimal CYP2D6 inhibition and is highly effective at managing tumor-induced hot flashes that can occur. Just another mention on tyrosine kinase inhibitor called neratinib that you may see in practice. It requires a highly acidic environment. So basically, we should try to substitute proton pump inhibitors with something like a H2 receptor antagonist or antacid, but ensuring that we separate the time. So basically, separate the time that we take the H2 receptor blocker or the antacid about 2 to 3 hours, right? Proactive support adjustments are a great start, but we also have to protect our patients from serious systemic drug-drug interactions. Right? So, safe substitutions at a glance: QTC, granisetron, not ondansetron; hot flashes, venlafaxine, not paroxetine; and acid suppression, HER2 blocker, which is adequately spaced, not a PPI. All right? So oral oncolytic adherence. When dealing with oral oncolytics, we must understand that adherence failures are highly predictable and completely preventable if we catch them before they result in disease progression. So there are certain reasons why patients may stop a medication. They may self-dose adjust because they feel a side effect and they feel better when they adjust the dose. Now, there's also schedule confusion. Sometimes, you know, they're going through a lot, then probably misunderstand when they're supposed to start, they skip the rest weeks, all of that. Financial toxicity is a very important one, but there's some companies have co-pays and have patient assistance programs. I know the NHF have compassionate funding that we can apply to. And sometimes the patients don't get anticipatory counseling from the physician, even though we do try, but sometimes because of the heavy load, you know, it might be missed. So they're not aware of the side effects to expect. So they're like experiencing these side effects. They don't know what to do. They have no way of contacting anyone. So they just stop taking the drugs. So what the pharmacist can do, and I know it's done already sometimes because I do get calls sometimes from the pharmacist about, you know, queries about medications and stuff, is to initiate counseling to the patient about expected toxicities. You can make the schedule clear to them. Proactive outreach, there are the primary dropout window is between cycle 2 to 3. So when the patient realizes, boy, I cannot afford this medication, you can help to navigate them with compassionate assistance programs, and, you know, helping them to navigate if they have health insurance, you know, do the pre-authorizations, all of those factors. So basically, the key takeaway from this is that adherence is rarely a motivation or compliance issue alone. It's almost always toxicity or scheduling or financial access problems in disguise. And a lot of these patients don't want to reveal when they can't afford the medication because they may feel embarrassed about it. So, you know, we just need to try and be patient. And this is just a quick look at the financial toxicity. It's not just a standard administrative issue, but I'm not going to go too much into this. But just to note that there are co-pay programs and patient assistance programs that are in place. And I'm sure over time, NHF would start to include a lot of these high-level drugs as a part of their subsidy programs over time, especially after this presentation. So, so these are things that I want you guys to take back to practice. So, As we close this program, let's distill the presentation into 5 routine habits you can implement in your practice. So the pharmacy oncologist should verify the subtype, because remember, over time we'll be dealing with some very expensive medication, and we can't just be dispensing medication to people that these aren't indicated. That's a waste of money and time, etc. And of course, exposing the patient to unnecessary side effects. So verify the subtype. Never let regimen pass verification without confirming that ER/PR, HER2, Ki67, and germline status are explicitly documented and aligned with the treatment intent. Rescreen for HER2 low. Actively look for IHC 1+, 2+ with ISH negative status. Run the drug-drug interaction screen every single time. Maintain automated and manual checkpoints for critical interaction. Stop ribociclib combined with ondansetron. Eliminate strong CYP2 inhibitors in tamoxifen patients, and completely block PPI use with neratinib. Now, own adherence proactively. Remember that patients cut their doses to manage side effects without telling us. Implement structured pharmacy phone calls, if possible, at certain cycles, especially when you see the patient don't come back to pick up the medication. Stay current. Keep the data from Monarchy, the key landmark trials and other trials that, because this is constantly changing. Keep them at the forefront of clinical decision making, and always remember the pharmacist is not merely the final administrative step in dispensing chain. The pharmacist is one of the primary clinical reasons the entire therapeutic process works safely and effectively for these patients, especially when we move to precision medicine. So to ensure we have these clinical and operational concepts fully locked down, let's test our knowledge with a few interactive poll questions. All right? All right, let's go. Okay. All right, so question 1. The poll was done already? Okay. They're responding. Okay. Okay, so I'll read the question anyway. A patient on ribociclib plus letrozole is prescribed ondansetron for nausea. Which statement is correct? So most people got it. Substitute granisetron to avoid the additive QTC risk. Excellent. Okay. So yeah, that's the answer. Excellent. Everybody got it. All right, so this is the next question. A pathology report shows ER 85%, PR 70%, HER2 IHC 1+, Ki67 32%. How should this tumor be classified? So I'll just give a few minutes. Now, the answers include luminal A, which is ER positive, PR positive, HER2 negative, low Ki67. Luminal B, ER PR positive, HER2 negative, high Ki67. HER2 low, IHC 1+ is now actionable regardless of hormone status. Triple negative, Ki67 above 30% overrides ER/PR positivity. All right, should I give any more time? Okay. All right, so it's a little bit of tie between B and C. All right, so let's look at the answer. So the correct answer is B, right? So the tumor is classified as luminal B because the hormone receptor is positive. So ER said 85%, 70% with a high Ki67 proliferation index of 32%. Now, the high Ki67 indicates aggressive proliferation and a greater sensitivity to CDK4 inhibition. So this patient is a candidate for CDK4 inhibition plus endocrine therapy, right? And yes, luminal Bs can co-express HER2 co-expression, can have HER2 co-expression, but this is the most accurate answer because that wasn't really in the other choices, all right? The next question, a patient with metastatic breast cancer previously classified as HER2 negative is being considered for third-line therapy. Which historical result would make her eligible for trastuzumab deruxtecan? A, HER2 IHC 0, B, HER2 IHC 1 plus or IHC 1 plus ish negative, C, HER2 IHC 2 plus. Okay, we'll just have a little technical issues. So go ahead and continue answering the questions.
All right, so everyone has attempted. You have 5 seconds literally remaining. And 53% of persons have said C. HER2 IHC.
Oh no, okay. Well, that's a good attempt.
All right.
Okay, so, okay, we're back. Awesome. So that's a good attempt. So the answer is B.
Answer is B.
You can go back so we can show the explanation. So the correct answer is HER2 IHC 1 plus or IHC 2 plus with ish. Now, just to recall that the HER2, if HER2 IHC 2 plus and ish positive, then that is HER2 positive disease, not HER2 low. It's HER2 positive and anti-HER2 therapy. That's a different pathway that we'd have to take. We're talking about defining HER2 low, which is IHC 1 plus or IHC 2 plus with ish negative. All right? Okay. Last question. A patient with early stage triple negative breast cancer, T2, N1, grade 3, is receiving neoadjuvant pembrolizumab plus chemotherapy per the Keynote 522 trial. What is true regarding PD-L1 testing? So, is it A, PD-L1 CPS greater than or equal to 10 is required for pembrolizumab in early triple negative breast cancer? B, PD-L1 CPS greater than or equal to 1 is sufficient for early triple negative breast cancer. C, PD-L1 testing is not required, benefit seen regardless of status. Or D, PD-L1 testing is required only if patient has metastatic disease. Okay. Okay, well, it's pretty close between B and C, pretty close. All right, so the correct answer is C. So remember, the Keynote 522 trial demonstrated a benefit in patients with triple negative breast cancer regardless of the PD-L1 status. And this has to do, as I told you, with the microenvironment is more inflammatory, and we're using chemotherapy to burst open cells and create a more inflammatory environment, so it actually works and is beneficial in the early breast cancer setting. When we get to metastatic disease, where the microenvironment is a bit different, that's when you'll require the PD-L1 testing. But still very good attempt, everyone. And I want to thank you. These are my references, and I thank you again for listening.
I am in awe, and I am just excited, and I am so grateful that beside me I had two women that had passion and energy, and if you see Dr. Foot beside me, you would get excited too. I am so happy. I have two questions already, and I want to share a joke with you that I pray and I pray that God take out vengeance on cancer. I think he has sent excitement in Jamaica, somebody who wants to take on treating our cancer patients. And not only that, I'm so very happy Dr. Sean Moncrief is here. We will talk about that. Yeah.
I hope I didn't get Dr. Moncrief in trouble.
I am so grateful you have him in trouble. So the first question that I have is, how many, Doc, how many of the drugs on treatment by subtype decision map are available here in the public sector in Jamaica?
Okay, so that's an excellent question. Okay, but seriously, we have different programs. So currently on the VEN list, and it's fully subsidized for all patients in Jamaica, regardless of whether or not they're public. Hospital is the Herceptin for HER2 positive disease. So that is fully subsidized with a partnership between, I believe it's Roche Pharma and the Jamaican government. So that's amazing. But we still need pertuzumab and the other anti-HER2 therapies. We also have a program via the Max Foundation, Max Access Foundation, which is an international foundation that helps to provide developing countries with medications like the CDK4/6 inhibitors, but only in the metastatic setting. When it comes to the early breast cancer, the high-risk ones, the patients have to pay out of pocket, and we can get the medications available to them, but it has to be paid for. There are other medications, not necessarily with breast cancers, in terms of the newer agents that are available, but you have to pay out of pocket. So, for example, the pembrolizumab is available, and there are compassionate programs and co-pay that I'm sure you can discuss with Aventa and other agencies about having. You have compassionate programs, right? I actually have a patient benefiting from access to that currently with triple negative breast cancer at my clinic in Mandeville. So I'm really proud of that and happy for that. But this is definitely a medication that we should definitely consider adding to on the subsidies as well as the VEN list, because it's so important. It's an important option for triple negative breast cancer patients.
I bless you. Thank you for that. And I know Dr. Sean is over there taking notes in his capacity. The next question before Sam does his questions online is, what is the prognosis for the average 30-year-old woman who presents with stage 3 triple negative breast cancer?
Boy, so or triple negative breast cancers, the prognosis for stage 3, it all depends. It's not just because we're in precision medicine. You have different subtypes of triple negative breast cancers that are actually chemo resistant, like for example like a metaplastic subtype, but we have been getting a more favorable prognosis in patients now, because we know we're finding them faster, we're diagnosing them faster, starting treatment faster. But the prognosis for an average 30-year-old in Jamaica is not as good, I must say. I don't want to sound too much of a Debbie Downer, but it really isn't as good because of the significant delays we have in our system. And one primary thing is that the delay in starting treatment. And then, of course, we have a radiotherapy issue where the machines, there's a long wait list, access to treatment. And the fact of the matter is we don't have pembrolizumab on the market currently, and a lot of it's about, I don't remember the cost of it, you guys can discuss the cost, but it is extremely expensive, and without the co-pay programs, and especially if they don't have insurance, many of these drugs are not accessible to the patient. So the prognosis is all dependent on if you have access to the treatment. But for the average patient, they tend to recur very early, and once you recur, it is so hard to treat them because they become more resistant and it's more aggressive.
Thank you so much. Sam.
Thank you so much, Doc. A few questions here. So, a lot of these drugs can be quite costly for our patients. For example, trastuzumab with 18 doses, running patients into millions, some even costing up to $1.5 million per dose, with a patient needing 4 or more. Okay, outside of the compassionate funds and NHF subsidies, which is not available for most of these, what other patient support programs exist out there relevant in the Jamaican context?
All right, so just to kind of tighten that's a good question. So just to tighten that, The Herceptin, the trastuzumab for 18 cycles, that is actually fully subsidized with the agreement between Roche and the Jamaican government. So that is for all Jamaicans. It's when we come, that's early breast cancer though, is when we come to the metastatic setting, we have a problem. So a HER2 positive patient who is metastatic will have to foot that cost. So sometimes there are compassionate programs international that we can look into. So like, the specific drug company may itself have compassionate programs that we just have to independently approach. You have Chase Fund, of course you mentioned the NHF Compassionate and the Ministry of Health Compassionate funding. But I mean, I'm sure we can work towards trying to get this covered on NHF at some point.
Thank you so much. What are the options and costs for genetic breast cancer risk testing in Jamaica?
Oh, sorry, just to go back to the question, the NHF actually covers the Herceptin.
Yes.
It's actually subsidized.
Wonderful.
Even though it's still expensive, it's covered for the metastatic setting, but it's fully subsidized for the non-metastatic. All right?
Thank you.
Sorry, repeat
the question was, what are the options and costs for genetic breast cancer risk testing in Jamaica? There's a second part which says, is radical bilateral mastectomy a recommendation common among persons testing BRCA positive?
Okay, so those are good questions. So in terms of the BRCA germline testing, there in all of the oncology centers, we do have a specific BRCA kit that is given to us via a particular company, and we do the testing fully subsidized by that company. So you can go to your oncology centers for it. But to get a more comprehensive testing, because it's not just BRCA, you have other different genes that are available. Okay, right. So you have other genes that should be tested to determine your risk of breast cancer. So there's a more comprehensive panel. I believe it's about $80,000, and there are different locations in Kingston that offer that test. But for the BRCA specific, there are actual kits at the public health system, and I think a lot of the private practices get these kits, and we can actually test the patients. In terms of the radical mastectomy, it's something that is actually pretty common once we have a patient that is BRCA positive. Of course, we have to counsel them first and have a discussion. And of course, there are options with reconstruction. So I find, at least with the patients that I see, that is usually an option that's chosen because everybody wants to decrease their risk. And it also, remember, it also has implications for offsprings and everything with other type of cancers. Additionally, a discussion would have to be dependent on whether or not maybe BRCA2 with oophorectomy, so removal of the ovaries. So there are risk reduction surgeries that are done and are commonly practiced.
Any other question? Not at all. I am saying get ready for a basket moment, because I'm going to give away a basket after this. Get ready also for a sponsor spotlight with Fairing. But before we get there, this kind of presentation must be applauded and rewarded. So I'm going to ask Sharon Alexander from Aventa to make a presentation to Dr. Foote at this moment.
Dr. Foote?
Dr. Jamie Foote. On behalf of Aventa Jamaica, I must say that this presentation was very informative and very insightful. And your depth of knowledge, clarity of delivery, and the practical perspective you have added to this presentation have truly made this topic much clearer to all of us. Thank you again, and we look forward to further collaboration with you.
Definitely.
Much appreciated.
Thank you so much for
Thank
inviting
you.
me.
Thank you.
So as we do our switchovers, as we do it so very seamlessly, the question right now is, list 2 oncology drugs distributed by Aventa. 2 oncology drugs distributed by Aventa. Let's go, let's go, let's go. That's a burning basket moment which needs to get off our hand. Yeah, come again, come again. We're getting there, we're getting there. Yes, 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 we have a basket winner. Fabulous. And here we are. Our presentation, our sponsors highlight comes to us from Ferring. Karen Kelly Reed is no stranger, and so she will therefore make a presentation for us and to us on behalf of Ferring.
Good morning, everyone. May I just say a belated Happy Mother's Day to all the mothers who are online. I'd also like to say and salute everyone who came from a mother. So that means I'm saying hello to everyone. As Ms. O'Sullivan said, my name is Karen Kelly Reed. I'm the Regional Sales Manager for Ferring for the English Caribbean. You will also know my colleague, I know she's around here somewhere, Kimone Fraser, fellow pharmacist like myself, you would have seen during the course of her work. I always love giving this presentation, especially after Mother's Day, because you'll see throughout the presentation that Ferring is so committed to reproductive medicine. And actually we own that space, and I say that without fear of contradiction. Our mantra and our corporate mission is around building families and helping people to live better lives. If you remember last year when I delivered this presentation, we were celebrating our 75th anniversary. People like to think that Ferring is new. We're not. We're an old company. We've been around for a long time. We're privately owned. We're currently headquartered in Switzerland. And we have around 7,000 employees globally, but we distribute to over 100 countries. And we have, we believe, the most comprehensive portfolio of products that take women from conception to birth. And I always like to tie in to the presentations that preceded me or are coming after me. So you would have seen that fertility came up in Dr. Dugan's presentation. And when we talk about breast cancer, something that we sometimes forget is fertility preservation for those patients who have to undergo chemotherapy. And this is why we like to remind our pharmacists that fertility, and you'll see why, and I know that in recent times you would have seen a lot of articles coming out about the fertility numbers in Jamaica. They are declining. We have one of the worst. We are now at 1.2 per person in terms of fertility rates, and that's not good. We need to be at 2.2 in order to replace the population and to replace the workforce. So our population rates are dropping. You will remember back in the day there was this campaign, 2 is better than too many. I think that was such an effective campaign. But now we are seeing the numbers go way, way down, and the fertility numbers are not where we need them to be to replace the population. So Ferring, we have one main mission: to be the most trusted healthcare company in reproductive medicine and maternal health. And you'll see why in a minute. Our global presence, as I said, is in over 100 countries. We have over 50, we're operating our subsidiaries in over 50 countries. Our partnership with Aventa spans, well, we were with Health Brands, which became Aventa. So we've been partners for almost 12 years now. We have 15 manufacturing sites, 10 R&D centers. This is what our executive committee looks like. I won't stay long here, but I just wanted to show you what our sales portfolio looks like. For us, 55% of our portfolio is around reproductive medicine and maternal health. And that's because we have a large portfolio of products that take patients entirely through their IVF cycle. We also have products in the portfolio that address fertility concerns such as fibroids, such as endometriosis, things that can affect fertility. We have products there, as well as the products that will take you through the IVF cycle, from stimulating the ovary, shutting down the GnRH system, stimulating, retrieving the eggs, freezing the eggs, and then fertilizing, etc. We have the products that take you right through. Many of you in the private pharmacy setting will see our endometrium a lot. That's because that's our progesterone product, which is used during those first critical 3 months, especially in patients who may have had a history of a miscarriage, and you need to increase the levels of progesterone in those patients. And our next portfolio, in terms of size, would be our gastroenterology portfolio, and followed by our urology portfolio. But I'll put the products up so you see them. Some of them you may know, you may not see them as often, but we have Menopur and Recovel. Recovel is very individualized. Dr. Foote mentioned individualized therapy. Recovel is our product that is individualized based on the patient's AMH and their weight, their body weight. We also have our Duratocin, which is our product for postpartum hemorrhaging. One of the leading causes of maternal mortality is postpartum hemorrhaging, excessive bleeding after the birth of the baby. We have our Duratocin. It has reduced the levels of maternal mortality across the world, and we're very happy that it is publicly available. It's available in our public sector here in Jamaica. I'm really, really excited. I know some of you may have already received this news by letter. I think Health Brands or Aventa may have sent out a notification, but the National Health Fund has recently added our Pentasa, which is our product for IBD. You'll see it in our gastroenterology portfolio. It has been added now in the individual benefits program. So I will use this opportunity to encourage you. Please let your patients who are on Pentasa know that if they go to them, get themselves registered for the condition with NHF, they will be able to take advantage of a very good subsidy given by the NHF. And of course, our third portfolio is our urology and oncology portfolio. And in recent times, you would have seen that the Firmagon, which is our product for prostate cancer, has been growing in its use. Now, you may say, so what's so special about Firmagon? But you will see that the sales, the prescriptions for the product have started to increase a lot. And the reason for that is, despite the availability of agonist therapy, many doctors are finding that Firmagon really is the ideal choice for prostate cancer patients who are metastatic on diagnosis. Now, if you think about the mechanism of action of the agonists, what the agonists do is that they stimulate the GnRH receptor to increase the levels of testosterone so that the brain will eventually have a down regulation of testosterone. Now, this is perfectly fine in low-risk disease. However, when you have a patient who is sitting in front of you, metastatic, already experiencing spinal compression, etc., you want to get control of the prostate cancer as quickly as possible. This is where Firmagon differs from what is available in the market. Firmagon is an antagonist of the GnRH receptor. So what it does is that it blocks the GnRH receptor. So your patient becomes castrated within 24 hours. That can only be achieved surgically. It cannot be achieved with any other product that's on the market. So what we have found is that our doctors have recognized, in using the product, have recognized how they get quick control of the disease, especially even in the hospitalized patients. So Firmagon is a product that it's currently, you will see it in the private pharmacies through the NHF subsidy that has been granted to the product, and we're very, very grateful for it. And we hope soon to have consideration for the VEN list, but and hint, Sean. But yes, this is why we're not saying it's for everybody, but we're saying for the patients who are metastatic on diagnosis, already showing that their cancer is moving. This is a product that is very, very useful for those patients. We also have our Uflexa for OA, and in endocrinology we have Zomacton. We have other products, but these are the main ones. So we're really very focused on patients, and we try to create products that work as the body intended. As I said, reproductive medicine and maternal health are the pillars of who Ferrin is. We have products, as I said, to prevent, well, let's start from the beginning. We get you pregnant with our fertility portfolio. Once you're pregnant, if you're having preterm labor, we have the only product that's actually indicated, designed to stop preterm labor, which is atosiban, which blocks the oxytocin receptor. Then you progress on to your delivery. And of course, there are some patients who have to be induced. We have our dinoprostone, Propes, which is a product that it's unique because it's delivered almost like a tampon. You insert it, you leave it, it ripens the cervix, and then you can move immediately into delivery. If you use oxytocin, for instance, to induce labor, you can't immediately move into delivery. You have to wait a little bit. So this product is very well used. We hope to have it here in Jamaica soon. It's not quite here. So now we've gone through the induction of the labor. A nice healthy baby is born, and unfortunately the patient is going into postpartum hemorrhaging. This is where our duratocin or carbitocin comes in, because this product prevents postpartum hemorrhaging. So as I said, we are the conception to birth company. If you hear Ferrin, just think conception to birth. And of course, in our gastroenterology portfolio, I mentioned our Pentasa. We also have Cortiment, Glypresin, Rebiota, PicoPrep, several products in this portfolio. And of course, our urology portfolio, which includes our Firmagon for prostate cancer and Minorin, which is our desmopressin, DDAVP, which can be used for CDI, central diabetes insipidus, bedwetting in children, nocturia in adults. And of course, our orthopedics and endocrinology. But it's a portfolio that's very specialized. You will see, sometimes you'll see it in the private pharmacies, especially with our endometrium and Pico Prep and Pentasa and those products, but then some are very specialized and are found in the fertility clinic, for instance. And I'll just leave with this slide. What is our R&D, research and development ambition? We stick to the areas that are we believe we're specialists on, which of course is reproductive medicine and maternal health, gastroenterology, and uro-oncology. Our latest product, which is being showcased right now in the AUA in the US, which is ongoing right now, is our product for bladder cancer, which of course falls in our uro-oncology portfolio. It's new. It's first in class, and we expect it to do very well. It probably won't be in Jamaica for another maybe 2-3 years, because the demand in the US is so high, and they're going to take their time in rolling it out. But our latest product, our product offering, is actually falling in our uro-oncology portfolio for bladder cancer. So I will leave with that. Thank you so much. Sorry.
Thank you so very much, Karen, for that wonderful presentation on ferrying. And I wrote it down: conception to birth, gastroenterology, urology, and uro-oncology. I want to also make an announcement, and thank you. I think we are going into our coffee break at this time. We must take care of our stomachs, but I just want to announce 2 winners of our baskets. Winner number 1 is Novadine Pollard Green, and winner number 2 is Alicia Smith. We definitely will be getting your baskets to you. We have one question before we go to coffee break. That question is, haven't heard Karen, haven't heard Shanda Edwards. I'm going to ask you this question. List 4 suppliers, we call them principals, represented by Aventa. Think about it. 4 suppliers represented by Aventa. 4 of them together. Ha ha. Aha. Oh boy. On the go. All right. What's that name? Wayne Barrett. Wade, you are indeed a winner. Yes. He has qualified. Yes. I am going to give away another basket very soon, so stay tuned. Sam, tell me where I am. Coffee break at 12. We return 12:15. Thank you so very much.
Legacy companies with diverse cultures have evolved together, creating a unique and dynamic Caribbean force. Aventa is a new identity for our group's pharmaceutical and healthcare business. Aventa evokes the word advance, and working together to advance health while innovating is at the core of our identity.
We want to be a regional pharma company and provide this simplified solution to the market and really deeply engage in the health ecosystem in the Caribbean. And that really helps where you have an identity that you can fly a flag behind. And we all understand what we're working towards together.
I think that I am excited about this opportunity because I feel it will open up the doors for travel and to experience the different culture in the different companies.
I'll tell you what I like about it. Nothing brings a team together like now operating under one name. So I look forward to seeing those synergies occur across all the organizations and all the companies.
For more than 6 decades, our Carlisle journey has been one of dedication, innovation, and care for our regional communities. Since 1961, our mission has been clear: to bring safe, effective medicines to the people of the Caribbean. Inside these walls, science meets compassion. Our people, from engineers and lab technicians to pharmacists, chemists, packers, and warehouse attendants, work side by side, each pouring pride into their craft. Because at Carlisle Laboratories, quality is not just a goal, it is the hallmark of our trusted brands. Our process begins with the highest quality raw materials and ends with a carefully packaged product, independently tested against rigorous international standards in globally recognized overseas labs. We operate under strict GMP guidelines with a culture that treats quality as a shared responsibility. Every process is designed to prevent risk, every decision backed by data, and every action guided by patient safety. Our staff aren't just skilled, they are guardians of the trust Carlisle has built for over 60 years. Within our state-of-the-art facility, we craft both prescription and over-the-counter medications to help manage non-communicable diseases, fight infections, and relieve pain. We are also proud to manufacture vitamins to support the good health of families, from children to the elderly. Every product we manufacture is for someone's mother, father, child, friend. That perspective guides every decision we make, from design to delivery. Every tablet, every capsule, every liquid we produce carries a promise to healthcare providers who trust our quality, and to patients who depend on us for life-changing treatments. From island to island, the Carlisle name has become a symbol of trust because we understand that efficacy, safety, and access to trusted medications are more than a requirement. They are part of the foundation of basic human rights. This is our commitment. This is our purpose. And this is why we advance health and enhance lives.
Something new is coming. Naturella 5-in-1 Cream. Natural ingredients, tones skin, reduces wrinkles, improves skin texture, moisturizes, has sun protection. Naturella. Be flawless.
Hi, my name is Glenys Durant, the CEO for Aventa Jamaica. We are proud distributors of the OR soap. We're so excited about this new partnership, and we're just looking forward to great things to come. Your skin, your story.
Hi, my name is Nicola Nelson Polak. I'm here with my favorite soap, OR. My skin, my story.
Hi, I'm Danielle. My favorite soap is OR, and this aloe scent, tea.
I'm John. My favorite soap, OR, my great fragrance, Olive. Your skin, your story.
Hi, I am Shakira Wilson Thomas. I am so happy to have OR for our personal care line, and this coconut scent is my personal favorite. Your skin, your story.
My name is Craig Williams, and my favorite is Aloe. Your skin, your story.
Hi, I'm Tony. I just want to put the girlies on. This is my favorite scent from OR Olive. Take a try.
Your skin, your story.
Glucolite. Hydrate with Glucolite Rehydration Salts. A great way to replenish electrolyte loss from vomiting and diarrhea, exercise, heat, fever and travel. Use 1 sachet to 1 liter of water and consume within 24 hours. Stay hydrated with Glucolite.
Okay, Natalie, which Carlisle product is your favorite to recommend?
Well, I would say my favorite Carlisle product is the Pista Tusing, as you can see here. It's suitable for almost all age groups in the family. So from 2 up can take it. It covers a lot of symptoms such as sneezing, coughing, irritated throats, runny nose, all that. Also, it's sucrose free. So if you are diabetic, this is perfect for you. So this is why I would think this is one of my favorite products from Carlisle to recommend for anyone.
Man, I been up in the hills.
Father God, big up yourself here. Nice and sweet.
Father God. Visit nature, beautiful.
We are here today at the Hollywell Recreational Park where the team just concluded our wellness hike.
It is part of a regional initiative by Aventa, or regional partners Aventa Trinidad, Aventa Barbados, Aventa Curacao. We all completed a wellness hike because at Aventa we're all about advancing health, enhancing life.
Silvercat, fast, effective healing. Silvercat provides fast relief of 2nd and 3rd degree burns and prevents infections on burnt surfaces, wounds, and chronic ulcers. Try Silvercat for all your wounds.
Euflexa is a hyaluronic acid, or HA injection, used to treat osteoarthritis knee pain at its source.
There are a lot of developments in medicine that are based on understanding the power of nature and the different molecules that nature is able to produce. With bioengineering, we can harness the power of those molecules.
Euflexa is made in an ultra-modern manufacturing facility in a manner that exemplifies the interface between biological and engineering sciences. Euflexa is different from some other HA therapies because it is not made from processed rooster combs. It is free of animal proteins and is safe to use in people who are allergic to poultry products. The manufacture of Euflexa starts with a special strain of naturally occurring bacteria capable of producing HA in high quantities. These bacteria are not genetically engineered. This beneficial bacterial species is grown under carefully controlled conditions and provided optimal conditions to produce hyaluronic acid that closely resembles the naturally occurring human form. The hyaluronic acid is then separated from the bacteria and subjected to rigorous purification procedures.
We use a very extensive procedure for purifying the hyaluronic acid. Once we've removed it from the bacteria, we proceed to do a series of steps to ensure there are hardly any contaminants, little or no residues of any other molecules present, to get as pure as possible a solution of hyaluronic acid. We also conduct each major step of the process in a separate clean room to help ensure the purity of the product. As the final step, we verify the purity of Euflexa using a battery of state-of-the-art analytical procedures. These tests confirm that endotoxins and other potential inflammation-causing impurities have been reduced to almost undetectable levels.
This manufacturing process for Euflexa results in a highly purified, non-avian, high molecular weight, single-chain hyaluronic acid that more closely resembles healthy human HA than any other HA product available in the U.S. for treatment of osteoarthritis knee pain.
Michael from Asa Pharma. I'm Carla Campbell from Asa Pharma. Today we are at the PSJ conference and we're highlighting today our featured product, Ryopan. It's an excellent antacid used to soothe heartburn. And the beauty about Ryopan is that it has an onset of action of 10 seconds. It's sucrose-free, it's sodium-free, meaning it's safe for your patients with kidney problems as well as diabetics. So when something burns inside, Ryopan.
Loratadine, tough on allergies. Fast, non-drowsy indoor, outdoor allergy relief. With just one dose, fast acting in 1 hour. Relief from sneezing, runny nose, itchy watery eyes, itchy throat, and nose. Get fast allergy relief that lasts 24 hours with Health 2000's Loratadine.
For more than 6 decades, our Carlisle journey has been one of dedication, innovation, and care for our regional communities. Since 1961, our mission has been clear: to bring safe, effective medicines to the people of the Caribbean. Inside these walls, science meets compassion. Our people, from engineers and lab technicians to pharmacists, chemists, packers, and warehouse attendants, work side by side, each pouring pride into their craft. Because at Carla Laboratories, quality is not just a goal, it is the hallmark of our trusted brands. Our process begins with the highest quality raw materials and ends with a carefully packaged product, independently tested against rigorous international standards in globally recognized overseas labs. We operate under strict GMP guidelines with a culture that treats quality as a shared responsibility. Every process is designed to prevent risk, every decision backed by data, and every action guided by patient safety. Our staff aren't just skilled, they are guardians of the trust Carlisle has built for over 60 years. Within our state-of-the-art facility, we craft both prescription and over-the-counter medications to help manage non-communicable diseases, fight infections, and relieve pain. We are also proud to manufacture vitamins to support the good health of families, from children to the elderly. Every product we manufacture is for someone's mother, father, child, friend. That perspective guides every decision we make, from design to delivery. Every tablet, every capsule, every liquid we produce carries a promise to healthcare providers who trust our quality and to patients who depend on us for life-changing treatments. From island to island, the Carlisle name has become a symbol of trust because we understand that efficacy, safety, and access to trusted medications are more than a requirement. They are part of the foundation of basic human rights. This is our commitment. This is our purpose. And this is why we advance health and enhance lives.
Hi, my name is Glenise Durant, the CEO for Aventa Jamaica. We are proud distributors of the OR soap. We're so excited about this new partnership, and we're just looking forward to great things to come. Your skin, your story.
Hi, my name is Nicola Nelson Polak. I'm here with my favorite soap, or my skin, my story.
Hi, I'm Danielle. My favorite soap is OR, and this aloe scent, tea.
I'm John. My favorite soap or my great fragrance, Olive. Your skin, your story.
Hi, I am Shakira Wilson Thomas. I am so happy to have OR for our personal care line, and this coconut scent is my personal favorite. Your skin, your story.
My name is Craig Williams, and my favorite is aloe. Your skin, your story.
Hi, I'm Tony. I just want to put the girlies on. This is my favorite scent from OR Olive. Take a try.
Your skin, your story.
We want to welcome you back to this other half of our CE presentation, and we are going to go straight into another sponsor's highlight. This time we are going to feature Health 2000. Welcome back.
Clinical use, mechanisms, and how to confidently recommend them in practice. First up, good day everyone. My name is Chris Porter of Health 2000. Today, I'll be briefly going through two of our topical therapies, Silvacant and SK-Derm, or Sk-Derm as some of you may prefer. I'll focus on their clinical use, mechanisms, and how to confidently recommend them in practice. First up is our burn cream, Silvacant. Silvacant contains silver sulfadiazine, a well-established topical antibacterial. It's mainly used for burns, wounds, and ulcers where infection prevention is critical. Silvercant works by releasing silver ions, which disrupt bacterial cell membranes. This gives it broad spectrum bactericidal activity, helping to reduce the microbial load at the wound site. In practice, it's commonly used for second and third degree burns, cuts, and abrasions. The goal is to prevent infection and support a clean healing environment. Application is simple, usually once or twice daily after cleaning the wound. It's also important to avoid unnecessary prolonged use. And remember, it should be used cautiously in patients with sulfur allergies. Now moving to a more complex skin condition, scaderm. Scaderm is a combination cream containing an antifungal, antibiotic, and a corticosteroid. It's designed for inflammatory skin conditions where infection is also present. Its main ingredients are betamethasone, clotrimazole, and gentamicin. Each component plays a role. The steroid reduces inflammation, the antifungal targets fungal organisms, and the antibiotic addresses bacterial infection. Together, they provide broad coverage and faster symptom relief. Typical use cases include infected eczema, dermatitis with secondary infection, and inflamed fungal infections. These are situations where monotherapy may not be enough. Scaderm should be applied as a thin layer once or twice daily. Because of the steroid component, use should be limited to about 1 to 2 weeks. Avoid using on the face, especially around the eyes, unless specifically directed. It's important to note where scaderm is not appropriate. It shouldn't be used for simple fungal infections, non-infected dermatitis, or long-term therapy. This helps prevent misuse and builds better clinical outcomes. In summary, decision making can be simplified. For wounds or burns, use Silvercant. For inflamed, infected skin conditions, use Scaderm. For simple fungal infections, use a standard antifungal such as H2K, ketoconazole, or clotrimazole creams. Bartotal, which isn't being discussed today, also has properties which can be used. To conclude, Silvercant is ideal for wound infection control. Scaderm provides multi-action therapy for complex skin conditions. Using the right product for the right condition leads to better outcomes. To keep it simple, Silvercant for wounds and burns, Scaderm for infected inflammatory skin. And before I go, just want to remind you of a few of our OTCs which you can recommend readily on a daily basis. We have our loratadine syrup and tabs, our Bartotal neem cream. For pain relief, we have our Go Gel, our multivitamin and mineral syrup, Vitamax, Naturella 5-in-1 cream, our Emerge, and the only flavored worm medicine on the market, our Worm Mizzle. And remember, you can download our MyH2K app, which you can get from the App Store or Google Play. And please follow us on our social media handle at Health2000 Canada. We here at Health 2000 would like to say thank you to all you pharmacists for your continued support over the years. And remember, keep dispensing H2K. Thank you.
Done for that comprehensive presentation. There's one thing that I'm going to ask you to do for us, those of us online and in our space. We want to know, we would like to know, where are you viewing from? We know that we have a high proportion of Jamaicans online, but if you're not in Jamaica, let us know. Well, yes, you're coming in from Halfway Tree, but those outside of Jamaica, let us know where you are viewing from. Yes, we see Mandeville, wonderful. St. Lucia, welcome. Manchester, Kingston, Antigua. It's going fast. We can't keep up. Belize, TCI, Cayman, Antigua and Barbuda. Welcome, Grand Cayman. Norway. Yes, welcome, Canada. Yes, even Clarendon, Jamaica. Montego Bay again, Florida. Junction St. Elizabeth, got to be Red Hills Road. Thank you so much. Thank you. Yes, Coral Spring in Florida. Yes, even Top Hill in St. Elizabeth. We welcome you. Toronto, Negril. Wow. Portmore and Spanish Town. St. Andrew. Fabulous. Clap yourselves there because that is wonderful. We really want to thank you. We have one other question because I have a basket itch and I would like to get it off my hand. And I want to ask the question, what's trending for Aventa? In other words, I need to know from you one new product that you are aware of. What's trending? They've got it already. They've got it already. Our soap. Yes. And so that is, Novadine get one already. So can we go to, that's who now? Jordan. Yes, congratulations. We'll get that name down and we certainly will have your basket to you. Wonderful. Here we are. The moment that we are waiting for. We have our lone gentleman who is with us, that is beside me. He has had to sit and wait on two women present. And as a woman, I am waiting on him, apart from Dr. Tyrone Smith, the lone presenter, because Dr. Tyrone opened us up this morning. And yes, he did, Kirk. And here we are. I have with me a sought-after man, definitely sought after by the distributors, by suppliers, by the doctors, by principals. And we have him here. He has been with us. We have had the opportunity and are grateful that Dr. Sean Moncrief from the Ministry of Health acquiesced to be with us today. And he bears a heavy load. He does. My friend bears quite a load, but he can manage. Tall, fair, and handsome. Dr. Sean Moncrief currently serves as Chief Technical Director for the Standards and Regulation Division at the Ministry of Health and Wellness, Jamaica. Having transitioned from full-time academia to central government in Jamaica in January 2025, he's committed to positively transforming the ministry's regulatory landscape. We pray for him indeed. Dr. Moncrief remains a senior lecturer and registered pharmacist, albeit part-time, at the University of Technology, where he has served for 25 years in many leadership roles, including program director, head of the School of Pharmacy, and acting vice dean across multiple colleges. He also serves as an adjunct lecturer in the School of Dentistry and the School of Pharmacy at the University of the West Indies, Jamaica. His academic credentials include his bachelor's from UTech, a master's in public health, postgraduate diploma in education, and a doctoral degree from of Pharmacy from the Ohio State University and an MBA also from UTEC. He's the recipient of a number of awards, one of them being the Jamaica Pharmacist Primus Award from the Pharmaceutical Society of Jamaica and the Pharmacy Image Maker Award from the Caribbean Institute of Pharmacy, Policy Practice and Research. Sean is no stranger to the matter of presentations. He is a frequent one, both in Jamaica and internationally. He has also published research papers, and his latest publication focusing on the impact of online school on the mental and physical well-being of pharmacy students at Jamaica's leading public university. I hand over to the man we've been waiting for.
Thank you so much, Gita May, for that introduction. You had me skinning my teeth like idiot. But all right, so I'll get straight into it. My presentation today, the topic, good distribution practice and the retail pharmacist. I know many of us as pharmacists in the retail sector, we don't think good distribution practice really applies to us. But hopefully after today, you'll think a little differently where this is concerned. And so the objectives are there listed. I'm not going to read them to you like CVM News. You can take a quick look at them, and I'll refer to them later on in the different segments of the presentation. Gita May mentioned that my affiliation with academia, and so it is hard to get it out of me after 25 years. So I'm going to start my presentation with a question, and I'm going to ask persons to quickly put in the chat their answer to this question. Why should medicine be of the best quality? You have 30 seconds. What comes to mind? I see to get the best result. I see safety, efficacy. I see patient safety, best results. Optimal treatment. Yes, best outcomes, efficacy. To offer the best outcome to others, quickly, patient safety, to be the most effective, quality of care, quality of life, very good, safe medication use, excellent, best therapeutic benefits. Yes, man, and a bright people. Thank you so much for responding. And all of them get a big ticky for those answers. Excellent. And so here are my answers to the question. Medicine should be of the best quality because they directly impact people's health, safety, and lives. Poor quality medicine will not effectively treat diseases, can cause harmful effects and death. And of course, high quality medicines ensure that patients receive safe, effective and reliable treatment. And there are two general guidelines. There are others, but two general ones that I refer to that impact medicine quality. Now, most times we hear about GMP, good manufacturing practices, and this one really focuses on the manufacturing of drugs itself, the methods used to manufacture drugs, the facilities in which they are manufactured, and the controls that are used during the manufacturing processing, and the packaging of the drug. That's what GMP focuses on. But then there's also the other guideline we refer to as good distribution practice, GDP, and this is where our focus will be. This one ensures that pharmaceutical products are safely stored, transported, and handled throughout the supply chain. Now, this slide really gives a look at the supply chain process of pharmaceutical companies. So of course it starts off by talking about the discovery and the development of a new active ingredients or new API, then manufacturing of that API, and then using that API to now formulate a new drug. having formulated this new drug, it then has to be what? Distributed. And who is it you're going to distribute it to? You're going to distribute it to the pharmacies. And then it leaves from the pharmacy to the patient. Now, this entire supply chain, quality must be an integral part of every single step in this entire process. Quality must be injected across the board at every single step. And we know today we're focusing on retail pharmacy. And so at the second to last step, we're talking about the drug reaching you, and then it's staying in your pharmacy, and then you dispensing it to the patient. And so my first objective, describe the core principles and regulatory expectations of good distribution practice and how they apply to community retail pharmacy operations. Community pharmacies are the final link in the medicine supply chain as seen on the diagram. Ensuring high quality medicine reaches the community pharmacy dispensary is critical. The handling of the medicine by retail pharmacists in a manner that ensures the maintenance of their integrity will determine the quality of medicine the patient receives. In other words, what you do, how you handle those medicines within your setting as a retail pharmacist will determine the quality of medicine that is dispensed to your patient. And of course, the final point is GDP, good distribution practice, provides handling and distribution guidelines that ensure sustained quality if you adhere to them. So GDP, it prevents substandard medicine, maintains safety, builds trust, and ensures compliance. So GDP is a key component of drug safety, and let's look further into that. It outlines the quality requirements for the distribution and logistics, the distribution and the logistics, how it gets to you, how it is handled, of human medicine, of veterinary medicine, as well as the active ingredients used in them throughout the entire legal supply chain. And you notice I use the word legal, all right? And of course, it aims to ensure quality, safety, and efficacy. And these are three common words that are used within the regulatory pharmacy setting. So again, it aims to ensure quality, safety, and efficacy of medicinal products, and that they're not compromised from the manufacturer to the point of delivery to your pharmacy. So we come to poll question number 1. Easy question. If adhered to, GDP ensures the quality, safety, and efficacy of medicinal products are not compromised.
Did anybody take any part?
Hold on.
Hold on.
Is would that get it wrong?
That person just did it differently. No, sir. Oh my God.
All right. Okay. So 97% of persons got the answer right. All right. The other 3%, come and pay attention. All right. So let's now move to the key principles of good distribution practice. And there are 6 of them that we'll focus on, looking at quality systems, documentation, training, storage, traceability, and of course, recall handling. Now, let's look further into it. And please forgive the grammatical error at the top of the slide. I won't ask who recognized the grammatical error. But let's look at the quality management. Necessary to ensure all distribution activities are properly controlled and documented. We made mention of the importance of inserting quality in the entire process chain. Proper storage condition is also extremely important. It's a very, very key principle within GDP. So the medicines must be stored under suitable conditions. So we're talking about things like our temperature, its exposure to light, humidity, and of course cleanliness. All right? And other key principles: stock control and rotation. Medicines should be organized and monitored to avoid expiration and avoid damaging of our products. So we're talking about utilizing the FIFO principle. First expiration, first expiry, first out. That's what the acronym stands for. So we want to use FIFO. First expiration, first out. And then, of course, there's a transportation and delivery. The medicines must be transported safely to maintain their quality and prevent damage or contamination. And when we think about the cold chain medicines, this is extremely important, especially where temperature is concerned. Receiving the medicine is also another key area that we must pay attention to. And that is something we do a lot in our private pharmacies. Other principles of GDP: prevention of counterfeit medicines. Pharmacies distributors should verify suppliers and inspect the products for suspicious packaging or labeling. Sometimes if we take a moment and really pay attention to the details of some of these labels and the type of packaging, it makes you pause and think, no man, no proper pharmaceutical company could never package a drug this way. It helps you to identify counterfeit meds. And of course, staff training and hygiene is also important. Staff must be trained in GDP procedures, how to handle medicines correctly, and to maintain hygiene standards. And handling complaints and recall is another important principle of GDP. Systems should exist for reporting complaints, investigating problems, and quickly recalling unsafe medicines. And let's not forget security of the medicines. The drugs should be protected from theft, tampering, and of course unauthorized access, and self-inspection and continuous improvement. Regular checks, audits should be carried out to identify problems and improve our distribution practices. Objective number 2, explain how GDP supports product quality, traceability, and protection against falsified or substandard medicines in the pharmacy supply chain. So, good distribution practice supports product quality, traceability, and protection against these substandard medicines. So, GDP, it supports product quality. Let's look further into that. So it helps to maintain the quality, safety, and effectiveness. How? We're talking about this, how it is stored. Is it stored under the proper conditions? The correct temperature, humidity, cleanliness. This is all a part of quality checks. And I mentioned already things like the cold chain medicines for cold chain medicines. So we're talking about things like vaccine, insulin, how they're refrigerated, and when they're being transported and stored, when they're coming to you, when they reach the pharmacy. Is it that the paper bag is hot? Is it warmed? or is it that it's cool? Did the truck that take it to your pharmacy have an igloo that stored those insulin or vaccines that might have been delivered to your facility? Rotating the stock through the FIFO, as I mentioned before, is all a part of quality, because you don't want to be receiving expired drugs, and you also want to decrease wastage. And what about damage? Sometimes if they're not properly packed and transported, sometimes they may be crushed. The contents may be, some of the tablets may break because they weren't packed properly, or they may become contaminated. That's all part of quality. And quality is also supported by how well you as your staff members are trained when they receive the medication. And of course, hygiene, people hygiene, very, very important. All right. Traceability, tracking those medicines through the supply chain from supplier to patient. Accurate records is what does it. The records must be clear. So records are maintained by the distributors, so they know exactly who purchased what, how much was purchased, and of course they can speak to how their medications are stored. But then there's also the pharmacy. How is the medication stored? What are the batch numbers? Do you keep these records of the invoices that come in? What about the expiration dates and so on? Do you have proper records of these things? Distribution records makes it possible for tracing where a medicine is from and where it was supplied. Who received the medication to? Proper documentation allows quick product recall if a problem is identified. So for example, if a manufacturer recalls a batch of blood pressure tablet, the pharmacy can identify quickly the affected stock and remove it from the supplies to ensure that it doesn't get, it's not dispensed, right? So your records are very, very important here. Protection against falsified and substandard medicine. We're talking about preventing fake, counterfeit, or poor quality medicines from entering the supply chain. Pharmacies need to purchase medicines only from licensed and approved suppliers. How many of you ask new persons, new companies that may come to you and want to supply medication to you, are you registered? How many of you check that sort of thing? Right? So pharmacies must purchase medicines from licensed and approved suppliers. Inspect for unusual packaging, labeling, damaged seals. These are sometimes little indicators that make you want to think again, should I stock this one or not? Report suspicious products to the regulatory authority. Just last week, I got one report from a suspicious product of a suspicious product. Secure storage and transportation reduce the risk of theft or reduce the risk of your products being tampered with. Okay, you don't want to receive tampered products because therefore you don't know about the quality of the product within the container itself. And of course, documentation and traceability will help to verify the product authenticity. Poll number 2, another easy cheesy. Pharmacists safeguard and maintain the integrity and safety of the medicine supply chain, and in so doing, they protect patient safety, prevent treatment failure, reduce harmful adverse effects, and stop circulation of counterfeit medicine. True or false? I don't expect anybody to be getting this one wrong, you know. What is it?
They're not.
Somebody is saying that it's being done to annoy me. I say 1% of persons getting it wrong. All right. I think those 7 persons that got it wrong, maybe cooking them food and not paying attention. Yeah, man, and then click a button. All right. So, objective number 3. Identify key GDP requirements for retail pharmacy storage and premises. So we're looking at things like our temperature, security, hygiene, segregation of return or quarantine stocks. So GDP requirements for retail pharmacy. Storage and premises are designed to maintain the quality, safety, and effectiveness of medicines throughout the storage and handling, or should I say, should be designed for that. And so, we all know what is happening these days with the temperature. The time just seems hotter than usual. So, we have to be careful here. Storage under conditions recommended by the manufacturer to preserve their stability and effectiveness. Pay attention to what the manufacturer says. But of course, we also have to bear in mind our surroundings, all right? So when we say room temperature, what are we talking about? 15 to 25 degrees Celsius. That's the temperature we talk about. Now, I know these days, and with the cost of electricity, some pharmacies may be shutting off their AC to help to preserve costs. But please bear in mind that in doing so, you also run the risk of speeding up the degradation of your pharmaceuticals within your space. And refrigerated products, when we talk about products must be refrigerated, we're talking about keeping it between 2 to 8 degrees Celsius. Please invest in a thermometer. That will help to monitor the temperature of your space, help to monitor the temperature of your fridge, and record these temperatures periodically. The literature speaks about you recording it twice daily, and that may very well be applicable now with respect to what is happening with the temperature, or ambient temperature, that is. And of course, we want to protect our medicines from excessive heat, direct sunlight. So if you have a window right behind the dispenser and the sun is coming through nice and bright, you may want to put a blind there to reduce the direct sunlight coming in. And of course, excessive humidity. And please make sure you have a backup plan for power outage. I think that the experience with Melissa has spoken loudly where that one is concerned. I know of one pharmacy that lost millions of dollars. Security of the dispensary and stock. Pharmacies must protect the medicines from theft, tampering, unauthorized access, and of course, diversion. And I also will insert here to prevent persons from also inserting on your shelves things that you did not approve. Sometimes persons may go abroad and do a little suitcase shopping, persons who don't belong in the dispensary, and then they come and insert it on your shelf. And you as a pharmacist may be very vigilant about what you allow on your shelf, but hey, somebody else who has access to the area will come and slip in a few shopping items on your shelf that are not authorized to be there. Okay, so security of the dispensary is very, very important. Put on secure locks. If you can put a surveillance system, that is good. And of course, where it comes on to the narcotic medication, that is a whole new ball game. Of course, these must be kept on the lock and key, preferably in some of these double-doored metal locking system. And let's not forget about the maintaining the records of our stock movement and our inventory checks. Ensuring delivery and receiving medication, that area should also be supervised. Hygiene. Keep the storage area clean, dry, and organized. I'll repeat that one. Keep the storage area clean, dry, and organized. I've seen some storerooms that, you have to wonder. Implement regular cleaning schedule for the shelves. And prevent pest infestation through pest control measures. I worked in a pharmacy that every 3 months, like a clock, the pharmacy, there was pest control maintenance that was done to prevent rodents and other pests from entering and doing what they shouldn't do. And of course, you do not want to have in your fridge with your medicine, food and drinks. Okay? I don't have to say much about that one. All right, so make sure your shelves are cleaned routinely to remove the dust, and expired packaging materials are disposed of properly. Now, what about the drugs that are returned or damaged or expired or quarantined? You want to make sure that these are properly segregated and properly identified. Okay, so whether they're talking about medication that you have to return or expired products, make sure they're all properly separated and documented. Make sure the packages are labeled. And you maintain a record of all of these drugs, whether it's going to be destroyed or retained. Records are very, very important, people. Okay, so moving on to objective number 4. Discuss the pharmacist's role in identifying suspected unregistered and counterfeit medicine. So pharmacists will play an essential role in protecting patients and ensuring that only safe, effective, and legally approved medicines are supplied and dispensed. Legally approved medicines are supplied and dispensed. So procuring medicines from authorized source. Purchase medicine only from licensed distributors. You need to ask questions. You need to see what's the proof of your registration. Call the authorities and find out if a distributor is licensed or not. Call the pharmacy council and you'll get that sort of information. Verify the supplier's license and documentation. Avoid medicines from unknown suspicious sources. You see somebody coming to you and offering to sell some medication to you for half the usual cost. That should send up a red flag to you. That should send up a red flag to you guys. All right? So be vigilant and think about it. It's not just about the money. You have to think about patient safety and so on. You can confirm if medication are registered with the Ministry of Health. That can be confirmed. Check invoices, batch numbers. Sometimes you'll see some invoices. You know invoices are supposed to be properly completed. Any proper run distributor or manufacturing company, their invoices will have on these basic items. Look at them, take a moment and read them. Don't just quickly, because you have 10 prescription line up, you just take and sign from the person that's delivering. Look at them and see, make sure that these things are there. And ensure proper labeling and manufacturing information are present. Sometimes we see some labels and you really wonder, is this for real? Simple basic things are missing about the product on the label. Okay. So inspect the package. We must examine our medicines for signs of counterfeit. What are some of these common signs? The quality of the product itself, the packaging damaged. Sometimes some spellings are off. You see printing mistakes, missing batch numbers. No drug supposed to be coming into your dispenser, you don't see a batch number on it. You don't see expiration date on it. No, man. A flag need to go off in you, a red flag. A little bell should go off in your head. Seals are broken. The tablet, all the colors are not consistent. All right? The size don't look too right. The color don't look too right. Is this a mold I'm seeing on the tablet? What's all this black spot on this tablet? Something is wrong. We have to sometimes pause, guys, when these things come, ask the questions, quarantine these products and investigate. Report to the regulator or authority. Once you identify or you suspect something is counterfeit or it's unregistered, provide the detailed information when you contact the regulator or authority. What's the name of the product? What's the batch number on it? The supply detail, where you get it from, where you saw it. The name of the nature of the suspicion. Okay? So these are some of the information that we would need as a regulator or authority to make a step in investigating these things. And of course, we must educate the staff and we must educate patients. So the training the staff to recognize some of these simple counterfeit indicators that I just spoke about. Talk to your patients about buying medicines only from licensed pharmacies. Do not buy things off the internet. Too often we see these things on the internet. Earlier on, the GLP-1 presentation occurred, and I remember about 2 weeks ago seeing an ad about, just log on to this and we can supply you with such and such of drugs. No. Talk to your patients about buying these things, not to buy these things on the internet. They are not safe. So the importance of your role as pharmacist is to help protect patient safety, you prevent treatment failure, you reduce harmful adverse effects, you'll stop the circulation of counterfeit medicines, especially when you talk to your patients about not buying it from these unregistered sources. You ensure compliance with laws and regulations, and you maintain public trust in the healthcare system. You help to maintain public trust in the healthcare system, and that's very, very important. So you must recognize that you as pharmacists, you're a vital safeguard in maintaining integrity and safety of the medicines in the supply chain. And so we must play our roles as pharmacists here to maintain the integrity of our supply chain. And this takes me to objective number 5. Apply GDP principles when counseling patients on the appropriate storage and handling of cold chain products after dispensing. So we start with counseling patients about how to store the medication, our biologics like our insulin, our vaccine. So let them know what the different temperature guidelines mean, what we mean by refrigerator. Tell them to keep it not in the door of the fridge, because when you open the fridge door is exposed to the ambient air. Okay, so the temperature at the fridge door fluctuates. Tell them to keep it in the middle shelf of the fridge, where you have more consistent temperature. Okay, refrigeration temperature is really 2 to 8. If you keep it in the door, I'm sure it will exceed 8. All right, so don't keep it in the door. Keep it away from the stove. Nobody keep your medication in that cupboard that's over the stove. Right? Or else you're going to cook it along with cooking a nice chicken, you're going to cook the tablets too. So no, tell them to keep it far from there. Do not keep it beside that window where you get direct sunlight. Excessive humidity. And of course, the persons who come to you and they buy their biologics, they buy their insulin, don't bother keep it in the car, put it in the glove compartment. So they may buy it early in the morning and they put it in the glove compartment. And when they reach home, that is when they take it out of the hot car and then put it into the fridge. If they're going to have to buy it early and keep it somewhere, well, they must walk with a little igloo or buy it on your way home, right? So talk to them about what to do when you have extended power outage. When I was an intern, I remember my supervisor shared with me this idea of telling the patient to, it was a patient who did not have a fridge. And he said, okay, the person of a fridge, tell them to put it in a plastic bag and submerge it in water. Just keep it in the water if you don't have a fridge. It will be cooler than just sitting on the shelf. All right? So it's sometimes some of the simple things that can be done to help to preserve the integrity of the medication in when you have certain power outage and so on happening. Store medicine out of the reach of children. Lock them away. Keep them in high places. I'll share a story. My students know I like to share a story. There's this lovely lady. Her name is Mrs. Moncrief. And she shares a story of her son by the name of Sean, who at 3 years old climbed up on the bed and entered the helper's handbag and took out her medication that looked like sweetie. And he ate several of them. They were actually her high blood pressure medication. And her son actually is in coma for days. So she tells that story. So you want to make sure your medication, tell the patients, lock it away and keep it very high so the children can't climb up. All right? Because you have some very, very inquisitive children around the place. Ensure your hands are clean and before you not only, before you take the medication, bottom line. All right? And of course, as patients, we must also check the expiration dates of the medication that is given to you. Tell the patients to contact the pharmacy if they notice anything off about the medication. Their parents, it doesn't look the same way that it usually looks. All right. So if they see anything that really bothers them, tell them to encourage them to call the pharmacy. All right. Now moving on to objective 6, which is our final one. We're going to now evaluate effective participation of the retail pharmacist in product recall. Now, a product recall occurs when a medicine, medical device, or medical health product is found to be defective, contaminated, substandard, it may be mislabeled, may be expired, or just potentially harmful to patients. Okay? So this offending product must be what? It must be removed from our shelves immediately. And of course, this is in an aim to protect the patients. So, we're talking about prompt identification of recall products. Now, who are usually the persons that issue a recall? The regulator authority, the manufacturers, and the distributors. Usually the regulator authority is the last, because when something is identified, usually hopefully a manufacturer will identify it early and initiate the recall. Now, if the regulators notice that the manufacturer is not issuing a recall, it is at that point then they tend to step in and do a mandatory recall. All right? Retail pharmacists, as a retail pharmacist, when you get this recall notice, you need to compare the details of that notice with your inventory, your stock. So that is why it's so important for you to have proper records. So you compare them, you identify, oh, this is the batch number they're talking about, all right? So I'm going to quickly remove these products from the shelf, and because you don't want them to stay in the dispensary area, you don't want anybody to come and accidentally dispense from them. So you may be off duty, another pharmacist comes in not aware that these have been recalled, and they start dispensing from them. So you want to remove them quickly, seal them off, separate them, okay? Make sure it's properly labeled, properly segregated. Proper quarantine procedure demonstrates compliance with GDP and protects patient from exposure to unsafe products. Communication. So we have a recall, you as a pharmacist, you have responded to it. You want to also communicate this to your other staff members, your technicians, the other persons who would work in the dispensary or around that space. Inform them what it is you have done, why is this recall out, and the reasons for your actions. It may be a situation that some of these the medications have been dispensed. Your records will allow you to then communicate to the patients who have received these medication. It may be a situation where you have to now ask them to bring it in and you'll replace it, or you refer the patient to the physician if there are adverse effects occurring. So clear communication will minimize panic, promote patient safety, and ensure appropriate follow-up care. What about the documentation? Extremely important where recall is concerned. Records must be kept properly. You must maintain accurate records. How much of this? What's the quantity of recalled products you have in your space? What are the batch numbers associated with it? What's the expiry date? All of this must be in your record. The data, when did you remove it? What date did you remove it from your shelf? The supplier notifications, patient contact, and actions taken. And of course, you're going to return whether or not you returned it or it was destroyed. So, good documentation supports traceability, accountability, legal compliance, and of course, audit readiness. If you didn't document your things properly, then you could not properly identify and you couldn't trace them properly. That's the bottom line. Traceability. Having done so as a pharmacist, you've removed the things from your shelf and so on. You also need to what? Coordinate with the author of the recall, whether it be the manufacturer that did the recall or the regulator authority that did the recall or a distributor. All right? So responsibilities include returning the recall products, completing recall forms, report adverse events or patient complaints, and of course following official recall instructions. So effective coordination ensures the recall process is completed efficiently and according to regulations. And of course, preventing future incidents. So as a retail pharmacist, you should evaluate how the recalled products entered your supply chain, whether procurement procedures were followed, the staff understanding the GDP and recall procedures. What happens after all of that? Of course, we have to evaluate our systems as a pharmacy entity, how can I improve my inventory management or monitoring system, strengthen our supplier verification, conduct staff retraining if necessary, and of course develop SOPs that speaks to exactly your steps when receiving medication into your entity. Continuous quality improvement reduces future risks and strengthens pharmacy practice. And so this now takes me to poll number 3. Select the item that does not belong below. The effective participation of the retail pharmacist in product recall is essential for protecting patient safety, preventing harm from defect or falsified medicine, protecting the doctor who does not know about the recall, D, supporting good distribution practice, preserving public trust in pharmacy service. Okay, it's getting there. All right, so I see 90% of persons have gotten this answer correctly. So recall is not about protecting the doctor who does not know about the recall. Okay. The effective participation of the retail pharmacist in product recall is essential for protecting the patient's safety, preventing harm from defective or falsified medicines, maintaining medicine quality standards, supporting GDP, ensuring regulatory compliance, and preserving public trust in the pharmacy service. And so an efficient retail pharmacist demonstrates vigilance and rapid response, strong communication, accurate documentation, and adherence to legal and professional standards throughout the recall process. And so as I come to the end, we summary. Good distribution practice is essential in retail pharmacy to what? Ensure that medicines remain safe, effective, and of high quality throughout the supply chain. By applying GDP principles such as proper storage, temperature control, stock rotation, accurate record keeping, and secure procurement, retail pharmacists help protect patients from damaged, substandard, and falsified and counterfeit medication. The retail pharmacist plays a critical role in maintaining medicine quality, ensuring traceability, identifying suspicious or unregistered products, and educating patients on the proper handling and storage of medication, including our cold chain products. So, through adherence to GDP standards, pharmacists support patient safety, regulatory compliance, and of course, public confidence in our pharmacy service, which is so important for us as pharmacists. And so as I conclude, ultimately, effective implementation of GDP strengthens public health and the healthcare system by ensuring that patients receive genuine, safe, and effective medicine at all times. And I will say genuine, safe, and effective medicine at all times. And I thank you all for your attention. And I think I turn it back over now to the team here.
We are now ready for your questions. And for Dr. Moncrief, first question.
Well, I was going to write it, but let me ask it. As it relates to stocking doctors who stock pharmaceuticals in their practices, and also the distribution through gas stations and supermarkets and wholesalers downtown and these places. I'm speaking specifically of class 1 drugs. Is there any mechanism for recall, etc., in those settings?
I think the recall process is not just about sending the information to pharmacies, but it's something that I think it's a greater audience that it's publicized to, and so wherever they fall, they should hear the notices, and if they're of good integrity, then they'll remove them from their shelf. So the notices should go wide, right, to ensure that everybody responds. But of course, also as distributors, you know exactly who you distribute your things to. So, and if you have proper records, then you should know exactly where the question batches are going or where they have been delivered. And so you should then also target these places, whether it be the gas station you delivered it to or the doctor's office, because you know some of the batches that are questioned are at these locations. Is that a question? I say a question there. Thank you. Okay, so you're talking about when we do GDP checks. Yes, there are. The audits at times reveal shortcomings in the distribution sector too, and the audit process involves informing them exactly where the should I say, the weak areas or the challenges have been identified, and and the fact that they need to fix X, Y, and Z. So yes, these are things that are picked up in the GDP audits that are done by the Ministry of Health and Wellness. Okay, thank you. I think that's the last question that came here.
So we got the last question. Today, the way we came in, we certainly are leaving otherwise. And I think that we would have come in without certain information, and we were provided with so much information, we cannot remain the same. And as I close off for yet another successful CE, virtual CE by Aventa, I want to remind all of us that your post-test questions will be sent to the email address that you used during registration. And so it's important that you know that your post-test questions will be sent to you via the email address that you used during registration, and that those test questions will be with you within the next 2 hours, so that the information remains very, very up to date, clean and clear in your mind. We don't want to wait another second. 2 hours, and I know I can hold Sam and Kirk to that. I want us in this room to just clap ourselves. We did a good job. But we're not finished as yet, because we are going to... Dr. Sean Moncrief, thank you.
You're welcome.
But a more official and formal thank you will be done by Kimberly, who is a pharmacist. So, you know, from one pharmacist to another, I'm a quasi-pharmacist. So, Kimberly, take.
behalf of Aventa Jamaica, I would like to sincerely thank you for your presentation on good distribution practices, as well as highlighting its importance on the quality, efficacy, and safety of our pharmaceutical products for our population. Thank you.
And so I'm inviting Shakira Wilson Thomas to come now and do the vote of thanks. From me, it has been a pleasure. I know this is family, and it's always so very good to see everybody who I see in the space and place where I am most comfortable. Thank you.
Miss Jeeta, thank you for being with us today, for representing this significant milestone for us. I feel like every time we do something important, you're there.
Absolutely.
And we thank you for bringing the vibes and keeping us on point.
Yes.
Thank you for your humor and your grace. You did a fantastic job as usual, and we really love and appreciate you. You are a valuable member of the Aventa family.
Absolutely. He's in the room.
Thank you so much.
Sam and Kirk, we thank you. Couldn't do it without you. Can't do it without you. Sam, you're so steady. I know. He's in the room. Sam.
Sam with the radio voice.
He does, doesn't he? Yes, yes.
It's not a podcast.
Oh boy. Yes.
Okay. Good afternoon, colleagues, esteemed guests, and everyone joining us online. As we bring this highly informative and successful continuing education seminar to a close, it is my absolute honor and privilege to propose the vote of thanks on behalf of the entire Aventa family. First and foremost, we owe a tremendous debt of gratitude to our expert speakers who shared their invaluable time on this Sunday, insights and clinical expertise with us. Dr. Keisha Allen Dugan, thank you for anchoring our morning with such a timely and comprehensive look into GLP-1 receptor, agonists, and obesity management. The depth of your presentation gave us brilliant clinical and practical insights into our critical area of modern healthcare. Dr. Jamie Lee Foote, thank you for providing such a vital breast cancer subtypes and treatment updates. Your presentation on clinical oncological advancements was both enlightening and deeply profound, reminding us of the critical impact of personalized medicine. Dr. Sean Moncrief, thank you for your incredible practical session on good distribution practice and retail pharmacy. As professionals navigating supply chain and retail landscape, your guidance on maintaining high standards of quality and compliance is invaluable to our daily operations. Thank you all for elevating our professional knowledge today. A special note of appreciation goes to our wonderful moderator and chairperson, although we thanked her already, Jeeta May O'Sullivan. Thank you, Jeeta May, for steering today's program so seamlessly, managing our interactive question and answer sessions, and with absolute grace and humor, and keeping us on track throughout the morning and afternoon. An event of this magnitude, broadcasting live virtually, does not happen without a dedicated team, working tirelessly behind the scenes. A massive thank you to the organizing committee for their meticulous planning, coordination, and execution to bring this seminar to life. To our technical and broadcast team, streaming live from 39 Hagley Park Road, thank you for ensuring a smooth, high quality, and seamless virtual experience for all attendees. Finally, to our incredible audience, the pharmacists, the pharmacy students, the medical representatives, and healthcare professionals tuning in from across Jamaica and the region, Thank you. It is for you that we put a seminar like this together. Thank you for your active participation, your excellent questions during the Q&As, and for your ongoing commitment to continuing education. Please remember to check your emails for the evaluation forms and details regarding the CE credits. Thank you all once again. Have a safe and wonderful rest of your Sunday afternoon, and we look forward to seeing you at our next event.
Though it's easy to pretend, I know you're not a fool. I should have known better than to cheat a friend and waste the chance that I've been given. So I'm never gonna dance again.